And is Dr. Merman here? Yes.
Sorry, for some reason I turned off my camera.
Hear you and see you fine now, Dave. And do we have a court reporter for today?
Yes, we sure do.
Is that you,
That'd
Wesley?
be me. Mm-hmm.
Great, great. I'm Owen. Thanks for being here. We can go on the record.
Give me just one moment and I'll put us on.
Thank you.
We are on the record.
Great. Today is December 5th, and we have two agenda items at today's Care Board hearing. I'll call the meeting to order. We have a budget presentation by the Brattleboro Retreat for fiscal year 26, and we have Rutland Regional Medical Center Notice of Service Line Reduction hearing. Before we get to those, I'd like to take up the minutes of November 12th, and I move for approval of the minutes. Sorry, November 19th, 2025.
I'll move we approve the minutes of November 19th.
And I'll say, all right, all in favor of approving the minutes, say aye.
Aye.
Aye. Aye.
Aye. And the minutes are approved. Today's hearing will be fairly condensed because we have a lot of substance to get to. So I'd like to just give the witnesses from Brattleboro kind of a sense of the timing, and also for the public, just so people aren't waiting around if they want to listen into one aspect of the hearing or another. So we'll have the Brattleboro Retreat presentation that will go from 1 o'clock to roughly 1:25 for their presentation. If you need to go a little over, that's fine. I then plan to take board questions of Brattleboro Retreat from 1:25 to approximately 2 p.m. At around 2 p.m., I would like to start the Rutland hearing and have the staff of the Green Mountain Care Board provide an overview from 2 to 2:10. And then the Rutland presentation from 2:10 to 2:40, board questions till 3:45, and then we will have at least probably 15 minutes to half an hour for public comment from 3:45 to approximately 4:15 on the Rutland hearing. And if we need to go a little bit longer, we can, but that would be, I think, the best way to fit in all of today's substance. I see Mr. Cummings. Mr. Cummings, are you and your team here and prepared to present?
We are here and ready to go.
Great. So I will have Mr. Henksler swear in you and your colleagues.
Thanks, Chair Foster. If I can have everybody from the retreat, I think we'll do it like this. I'll read the oath, and then I'll have each member of the retreat please individually state your name and then affirm the oath. That way the court reporter has each person's name as well. And you can just go ahead and unmute yourselves individually or all at once. Do you solemnly affirm that the evidence you shall give relevant to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
Stephen Cummings, President and CEO of the retreat, and I do affirm, yes.
Jill Meschke, Chief Financial Officer of the retreat, and I also affirm.
Carl Jeffries, I am the Chief Medical Officer at Brattleboro Retreat, and I affirm.
Great, thank you. And we'll turn to you, Mr. Cummings, and your team for your presentation.
All right, thank you. I'm going to share our slides. And you can see that okay?
Yes, we can.
All right, great. And we only have about 10 slides, so I think we should be able to stay within the timing that you outlined, Chair Foster. Thank you very much for giving the opportunity to present our budget. What I'd like to do is, we're following the outline from the guidance, and so what I'd like to do is just a brief introduction and then get into a little bit more detail. So just by way of starting, the retreat has been around for 190 years, providing mental health care. And as we have for the last several years, We are still staffing 100 inpatient beds that provide care for adults, children, and adolescents. We also have a residential unit for children, and then we have, as you can see, the sub-bullets here related to our outpatient services, which involve one-on-one couples and family counseling in our Anna Marsh Clinic. We have a pretty robust intensive outpatient and partial hospitalization programs for adults. Those are essentially group therapy programs. And then we also have some specialty programs targeted at treatment-resistant depression for using transcranial magnetic stimulation and specialty medication, specifically esketamine, which you'll be hearing more about as we go through the presentation. I think the other thing that I'd like to just point out quickly is that we have a good working relationship with our colleagues at the state and work really closely with AHS and the departments there for DMH, DCF, DIVA, et cetera, to really shape what we're doing, because they are a big part of the work that we do, and we care for a lot of the patients across our state. As you know, we admit patients from every hospital across the state. And so in light of that, what you'll hear more about in our plans is for the reopening of our adolescent psychiatric residential treatment program. And then we're also making some incremental changes on the outpatient side to add to the intensive outpatient program, add another group for adolescents to give them a group that makes more sense for them with a provider there. And then also a discharge follow-up clinic, which Dr. Jeffries will talk about these in just a little bit more detail a few slides down. So background from the last year, just to cover a couple of basics, there's been no change in our corporate structure. We have had no real significant changes in our service lines of any kind. As I referenced, there are some programs coming up for next year. We had initially hoped and had in our budget to open the adolescent, I'm going to refer to it as the PRTF, the residential treatment facility for the adolescents. And we had hoped to open that in the middle of 2025. And it was, as you can see, planned to generate some pretty significant revenue for us. This was started related to a request for a proposal from AHS. And so this has been a process going forward. That program didn't open for really two primary reasons. One is the electronic health record go live that I'll talk about in a minute. And the other is just, again, working closely with our state partners to come up with a plan to effectively have the startup funds to launch that program. There's some significant expenses up front before we start to generate any revenue. And so we wanted a good, sustainable plan. And we think we've got that for 26. We'll talk about that in a little bit. So we didn't launch that program in this calendar year. We did make a huge investment in an important investment in our new electronic health record. We moved to a Meditech platform from a much older NetSmart system. That system brings some new efficiencies for delivering care and for our documentation process. It has capabilities for interoperability, so it allows us to share and consume records from the hospitals we're getting admissions from and places we're doing discharge to, with a much more robust set of tools that will work much more effectively with Epic, Cerner, and other vendors than our old vendors. So a lot of our work will be to work with our partners to launch those tools and start using that. It also gives us a foundation to start applying some AI technology. I won't go into all the exciting details about that. We're going to take a cautious approach there, but look for ways that we can leverage that. And then also what you'll see is some expense reductions. As you're implementing, you're paying for two EMRs, the old one and the new one during the 12+ month implementation process. Now that we're live, we're only paying for one primary EMR and just a backup copy of our old data in the old system. So that plus the consulting costs that we had to help us launch that were significant investments that we made in 2025. So with that, I'd like to turn it over to Jill to go through a couple of slides with sort of the hard numbers that we're looking at for fiscal 26. So Jill?
Thank you, Steve. So this is just a high-level summary income statement of what we had in our 2025 budget, what we are projecting to end 2025 with, and what we have submitted to the Green Mountain Care Board for 2026. So just a couple of high-level notes. In our primary service lines between inpatient, outpatient, and residential therapies, in our net patient revenue, about 70% of the gross charges are related to our inpatient hospital, and an additional 10% are related to our physicians in the inpatient hospital. So a good 80% of the revenue that the retreat generates is related to those 100 inpatient hospital beds that we staff and care for our patients in. The remaining 20% is about 14% outpatient and 6% residential in our 2026 submitted budget. So that does include the PRTF that Steve referenced earlier. When we look at other operating revenue, that's mainly just a few grants, some small dollars from our cafeteria, and a little bit of rental revenue as well. You can see projected in 2025, we have a much larger number that was in our budget for 25 or what we're submitting for 26. In 2025, we, with the assistance of our financial auditors, were able to apply for and receive about $8 million worth of employee retention credits from the IRS. So those are one-time credits that we will not be receiving in the future. That was for 3 quarters of our work that we had done in the more COVID era timeframe. So that's why you see a significant difference there. In terms of operating expenses, our salaries and wages are the biggest component of our salaries and wages. We'll talk about that in another slide or so too. But they are increasing by about 12%. Most of that is related to hospital staffing needs. Although we're not changing our revenue very much with our hospital staffing, we are finding that as we transition from contract labor to more core staff employed positions, that's really driving a big part of why our salaries and wages are going up in 2026. Contract labor, on the other hand, is decreasing by about 44%. So we're really focused hard on managing our contract labor costs at the retreat. We have some expenses in our benefits line item. I believe Steve talks about that in the future here in the presentation. We're absorbing a lot of those costs at the retreat rather than passing them on to our employees. So those items are going up by about 12%. And then finally, all the other operating expenses are decreasing by about 2.4%, and that nets us out to the 2.8 operating expense increase budget over budget that we're looking for. Next slide, please. Thanks. So just to reiterate, the budget benchmarks all met guidance related to what the Green Mountain Care Board has requested. Our net service patient revenue increase is 3.5%. Which achieves that mark to go to 3.5%. Our commercial rate increase is achieved at 1.2%. So we did have some increases in the smaller payers. If you recall last year in our presentation, we had indicated that we were really working with our payers, commercial payers, to negotiate rates that were in line with what our government payers are paying us, to make sure that we're not subsidizing commercial costs with governmental dollars. So we do have some increases in some of our smaller payers, but for the most part, our larger payers, we did not experience any change for our 2026 budget. And then finally, operating expenses, like I mentioned, are rising 2.8%. So we're just under that target of up to 3%.
Right, one more slide. Go ahead, Jill.
Oh, you want me to handle this one too, Steve? I think
Yes,
I
please.
do. Okay, great. So in terms of our patient care revenue, our payer mix has not changed significantly. 65% of our payer mix is Vermont Medicaid. We did experience over the last 2 years now, some increasing payer mix in our Vermont Medicaid population. It's driven by demand, and you see that reflected in our alternative payment methodology agreement with the state of Vermont. In prior years, we had up to 51 beds paid for on a daily per diem rate, and now we're seeing 56 beds on that prepayment daily rate. So that's really an effort to level out the payments as we're seeing patients rather than having a large reconciliation at the end of the year. And then we also do have 20% Medicare and 15% commercial. So you can see that Vermont Medicaid makes up a significant amount of our book of business, both in our inpatient side and in our outpatient side of our businesses. Case mix doesn't really apply to Retreat as an inpatient psychiatric facility. Our reimbursement is based on negotiated per diem rates for inpatient care. So with each of our payers, we negotiate what a fully charged daily rate would be in order to have patients stay with us in the hospital. And then Medicare reimbursement does include a per diem rate and a DRG adjustment factor of 1.0, and that's been unchanged since 2021. And then finally, bad debt and free care trends. So we have listened to the Healthcare Advocates Office and to our own patients, saying that the process is complex and confusing. So we've done significant work within the year of 2025, in the year, to simplify and retrain our staff on the financial aid policy. Most of the requests that we get come from our outpatient programs. We have 2 excellent financial counselors who work with patients to help them gain access to the Medicaid program if they qualify, and really are willing to be their advocates as they move through the paperwork and make sure that they're being followed up with and have access to all the support that they need as they complete paperwork. And then just a note, as we see some changes coming on the federal side of the Medicaid reauthorization requirements, as this potentially could increase uninsured Vermonters as the premium subsidies sunset, we may have an increase in the need for bad debt and free care services at the retreat, and also for our financial counselors to continue doing the good work that they do. As we learn more about this, we'll continue to work closely with our patients and support them in staying enrolled as appropriate.
Great. Thank you, Jill. And I just want to add one more comment that we are asking this year for a lower commercial rate increase than last year, where the board allowed us an aggregate increase of 6.7% to sort of right that balance between commercial rates and what we're getting at Vermont Medicaid. We've achieved that through some negotiation with all the payers that we significantly do business with. And so that allows us to sort of come back into line in that guidance so that we can manage that. And I would also just reiterate too, on the Vermont rate, that from 24 to 25, our rate actually dropped 9% to the state, which was a significant hit to our revenue, but I think we're holding our own with that. And that rate will now stay flat in going into 2026. So I think we're working hard again with the state to try to maintain that level of care, but at an affordable cost. So with that, I'm going to move forward. And we're going to talk a little bit about shifting to revenue. And what I'd like is for Dr. Jeffries to just take us through just a little bit more depth in some of these, the PRTF and the outpatient services that we're doing a little bit more with this year. So Dr. Jeffries.
Thanks, Steve. So I am very excited about some anticipated evolution and expansion of our service lines. For the past several years, we've been working on evolving and expanding our continuum of care for children and adolescents. And so reopening adolescent residential care is an important part of that. We anticipate being able to do that in July. and adolescent services, adolescent residential services are a need throughout the state. And they serve to divert potential inpatient admissions for patients who maybe are struggling in the community, but maybe don't quite meet that level of care, but need high level of intervention, as well as serving as a resource for stepping down from inpatient level of care once those adolescents have completed their crisis stabilization. It is it's going to be a 15-bed unit, and it's going to be in an area, a new area on the campus that is continuing to be worked on and upgraded to meet that service line. We are also anticipating opening up an intensive outpatient program for adolescents, and this one we hope to open in March. This is going to be a virtual intensive outpatient program that is in order to.
I think Steve's screen was frozen, so he had to probably reset.
Okay. So I'll keep talking about the intensive outpatient program. What we hope for is to be able to serve adolescents who are in need for higher level of care, but again, don't meet inpatient level of care criteria. And the idea behind a virtual program is that it will serve adolescents in their home and allow them to maintain what we hope to be some level of functioning while they are receiving these intensive services, like being able to continue to go to school and engage in home activities. And then the telehealth aspect of it also allows us to just reach a broader community throughout the state. We are also planning to what we are currently calling a discharge follow-up clinic, but really we think of it as an extension of our inpatient services. And what we are trying to do is meet a need that we have long identified due to just limited resources throughout the state. So when we have inpatients stabilize and we are transitioning them back to the community, what we want to do is have a very smooth and close handoff into the care of community providers. And with limited resources, sometimes there's an extended period of time, and sometimes it takes a while for people to even identify appropriate treatment providers. And what we know is that the 30 days following inpatient stabilization are really the highest risk time frame for many of our patients. And so what we are working to do is develop a case management heavy support system to get patients followed very closely during the period of time following discharge until they can get into the care of their new outpatient providers or their existing outpatient providers. And then we will also be providing a very short-term psychiatric care for patients if it is needed. But we do expect this service to be a pretty heavy case management service. And because case management is not currently reimbursable, we don't expect this to be a large revenue generator. But we do anticipate that we are going to be able to provide this service, and we recognize that it's a much needed service. Also in 2026, we are going to continue the work that we've been doing in our outpatient clinic and our Marsh clinic to expand the services that we can provide and increase access because there has long been very high need. We, in the past 6 months alone, reduced our wait list from near 300 on the wait list, and an anticipated wait time to get into care of out to 1.5 years. We are currently now down to 20 patients, very markedly reduced wait times for people to get in, and we're very excited about that, and we are going to plan to continue that work. We don't want a wait list, and we want to be able to have people who reach out and get referred to get into care very quickly. And we are achieving that through a couple of different, several different approaches. we have opened up a psychiatric service line only level of care. In the past, psychiatric services were tied to therapeutic services, and that was an obstacle to some of our patients, and some of our patients only needed psychiatric care. And we are also continuing to increase our telehealth access. We've been working on that over the past many years, but we continue to increase that, which allows a broader reach for the communities that we are going to provide services for.
Thank you, Carl. And I'm going to apologize for the blackout in the middle of your presentation. I had to restart Teams. Perfect timing. All right, I'm going to just run through the last couple of slides that we have, just to recap on a few things and talk about some expenses. So as Jill has reported out, our expense growth for 26 is expected to be at 2.8%. And as she mentioned, wages and benefits is a big piece of that. I'll have another slide that shows our transition from contract to core staff that I think also feeds into that a little bit. So it's not all a bad story as far as those expenses going up because contract is coming down. We are also looking at, and I mentioned this earlier in the slide on the finances about the APM contract we have with the state, and that rate is staying flat through this year after a pretty significant discount reduction last year. And then really as we're trying to achieve some of the efficiencies Dr. Jeffries talked about on inpatient and outpatient is beginning to leverage just basic things like voice recognition technology with Dragon and so on attached to our new EHR so that our providers can generate notes more effectively. So we'll be looking at that and some other technology to help improve those efficiencies. And then I just want to touch on pharmacy costs again just a little bit. We're projecting a 5% overall cost increase for pharmaceuticals. Much of our meds on the inpatient side are just rolled into the per diem rate. So the changes that you might see are more on the outpatient side. And esketamine is the only med that we administer in an outpatient setting for depression. And we're expecting to see higher volume there. So higher utilization is the biggest part of the increase in the cost for this med. It's a pretty expensive med. But the vast majority of that increase is related to increased volume that meets the demand that's there, and also our ability to get patients screened and then into the program more effectively. I think there's a lot of factors that went into being able to provide more services with this treatment. So I just wanted to point that increase out. It looks like a gigantic number, but it's not thousands of patients. And so we expect that we'll be able to provide a little bit more treatment in that mode. And then this is the labor slide, and I really wanted to just focus you on the graph at the bottom. And if you look across from 2023 to current, the blue lines represent our core staff, and the orange lines represent travelers or contract labor. And you can see the trend and how that's moving in the direction I think we all want it to. So that's really the story of why I think that we've been successful with some of the investments we've made. We are trying to really take care of our employees, not just with a wage increase, but with good benefits where we try to cover these costs increase for them. We are transitioning to using some on-campus housing that we've had used in other ways in the past so that we can have folks come in, work a string of 12-hour shifts, and be able to stay in a safe, comfortable place right here on campus so that they can work a 12, get some rest, come back and work their next shift without having to make a long drive home. And that's been a big factor in helping our staff consider us, even though they might live further away. And then, you'll see in our narrative, we spend a lot of time talking about the range of training that we provide our staff. And I just want to focus for a minute on the mental health techs and the RNs, and that we've really invested in a great clinical education team with really defined programs to take people through their a progression of really learning more skills at these two key levels. And so where we're at today is we only have about 31 contractors on site. This week, I get a weekly report that tells me the exact number of bodies. And then I can also tell you that I was just looking at my orientation group for Monday coming in. There's 13 people starting. 6 of those people are former travelers who are converting to core staff. And that just is more evidence of how we're moving forward. Last thing I want to touch on, the last slide, is around capital and those expenditures. We did manage to get a grant from the a FEMA grant from the Vermont Department of Public Safety and Homeland Security Grant Unit. This is going to go towards improving the security around our main entrance. It's a very vulnerable site. And as we look at some of the things that have happened in other hospitals in the region, we want to harden that entrance, make it safer for employees and visitors as well. So we got a grant to cover that. There's still some significant expenses on the information systems side, not on the EHR anymore, but to replace a really aging copper phone system. That's the majority of what that $710,000 is. And then some network infrastructure to support that, as well as some cybersecurity work that we need to maintain, as well as just updating the end user devices. That's a constant thing that we rotate through devices. And then on the facility side, again, a fairly large number. We win the contest every year for age of plant. We're going to be over 24 years this year. And so we have some much older elevators that need significant refurbishment. We need to replace some control panels on our electric generators for backup when we need electric power. And then the roof on the Osgood building, which is one of our patient care buildings, also needs to be replaced. So that, along with the contingency, are some expenses we're looking to try to manage over the next year or so. And we're going to continue to look for grant funding and other opportunities for how to cover those expenses. So with that, I'm going to conclude our presentation and turn it back to you, Chair Foster.
Great, thank you all very much for the overview. I'll start with Member Walsh for any board questions.
Thank you, Chair, and thank you, Brattleboro. Research evidence recommends that inpatient psychiatric capacity of roughly 30 beds per 100,000 people at a minimum. Vermont's total inpatient psychiatric system, including adult, adolescent, and flex-capable beds, operates well below that. So no single institution in the state can meet our needs, which to me makes it vital that we understand your budget assumptions and its accuracy and realism. So I have just a couple questions about that. Your FY26 budget projects modest increases in volume and revenue compared to your 25 budget, but the increases are fairly large compared to the projected figures for 2025. Could you walk us through how you validated those assumptions to be sure they're more realistic than aspirational?
Not sure I 100% understand the question. I think you're really asking how did we arrive at the projections for what we believe we'll see for patients in 2026 compared to what we're actually going to see in 25?
That's right. And how did you decide that those are realistic rather than aspirational?
Okay. I'm going to ask Dr. Jeffries to help me out, but I think that one of the things that impacted our census for 25 that was fairly significant was actually the electronic health record go live as well, in that we had to reduce census for a period of a couple of months to be able to staff the huge work that we had to do as far as training and backfill staff. So we actually closed some beds to try to be able to accommodate the demand on staff's time. So I think in that sort of middle couple of quarters of the year, we saw a dip that was intentional on our part. And, you know, I think one of the other challenges is that there are peaks and valleys that we just don't have that much control over. You know, we can anticipate that typically we're going to see some drop in adolescent and some children being admitted during the summer, and they tend to get back into school, and we see our numbers come back up. But sometimes we see dips. You know, today our children's unit is at about 50% capacity for a couple of days, but it was full just a couple of days ago. So what we're trying to do is work with the state and work with our partners from the hospitals to make sure we understand what else is going on at the state level and with our other partners that may have bed capacity. And then also looking at what's going on in neighboring states. What happens in New Hampshire affects us to some degree. So we've tried to look, you know, month by month at each sort of cohort of adult level ones and voluntary adults, and then the adolescents and children, to get a sense of what we believe the volumes are really going to be. I hope that helps a little bit. Dr. Jeffries, I asked Dr. Jeffries to help us with those estimates because he has the best information, but I defer to him.
That does help. And just to be clear, I think the services that you provide are vital and needed. And my questions, I'm hoping to help understand that more about your budgeting process so that we can make sure that we're approving a budget that is realistic and helpful to your solvency.
Yeah.
And so I understand that you narrowed your capacity for a while in 2025. And I imagine that you were able to track how much business was lost during that time and then add that back into what 2025 would have looked like had you not done that, and then made projections for 2026. But I was trying to ask about how you validated those assumptions and that modeling. I think a similar question about the OpEx growth. Your modeling, budgeting for 2026 OpEx growth that's less than inflation, and you've done a great job reducing reliance on contractors and reducing your operating expenses. But now that you're through that process, how are you planning to maintain that low level of operating expenses? And how sensitive to that is, how sensitive are those low operating expenses to changes in your volume?
Mm-hmm. So I think what I could also add there is that in addition to the work on contract labor that we've already covered, there are other aspects of our operating costs, and I'm an IT guy, so I tend to migrate towards those. But because we've standardized now on an electronic health record, we can work with and leverage, and also on a Microsoft Office, a Microsoft 365 and Teams platform. Those are the two core platforms that we're going to now reduce several other duplicate applications that we use that do some of the same things. We already pay licensing for these two big platforms, so why would I buy more applications that do the same thing? So we're going to be investing in projects to reduce and eliminate a number of those types of systems. I think another thing that's a little more nebulous, and I'm going to ask Carl to talk about this a little bit, but also just looking at our staffing ratios and making sure that we are as efficient as possible, because I think, again, this is a thing that ebbs and flows with acuity. But Carl, could you talk a little bit about what we're starting to look at there related to staffing ratios? Because that likely is going to be one of the bigger factors in how we manage expenses.
Absolutely. And that is something that we use as part of our modeling and anticipation for next year, because in addition to just things like the 6 months leading up to the go live and the training that was required and the staff attention on just the build and all of that other stuff, limiting staffing resources. The other thing that is very heavy staff focused is managing acuity with staff above and beyond our anticipated grids. And there was a very heavy need of that throughout this year in ways that were inconsistent with previous years. And so we are working on developing a program, and we have set goals that we are going to utilize those extra staff at double time, triple time, maybe not triple time, but they are very heavily very cost heavy when we have to bring staff in to do extra work and have extra staff when they weren't actually scheduled. And so we are working with our new quality team and our new clinical, our continuing to expand and evolve clinical ed team with projects to continue to try to minimize the use of those additional staff resources.
I also want to add that with the residential treatment facility not opening in 2025, that we had projected almost 6 million in revenue that never showed up, and that we made a lower, more conservative estimate for 2026 for that program with a more controlled and more conservative ramp up for that program. And now that we haven't got a signed contract yet with the state, but we have agreed on the rates. And that we feel very confident in those numbers, that if we can launch that program in July, that we're gonna hit the numbers that we're projecting. That's one of the biggest things that we have to do, is open that program on time.
Great. During the last winter, during the SVMC Certificate of Need proceeding, the retreat argued that the paradigm had shifted and that there was less need for inpatient psychiatric beds than had been identified in 2022. And with their adolescent capacity expected to come on in 2027, can you help us understand the rationale for continuing your expansion plans?
Well, we're not expanding anything on the inpatient side. And the residential, the PRTF adolescent program is a lower level of acuity than the inpatient beds that SVMC is planning to launch or start up in 2027. It's actually a place where patients on our inpatient adolescent units, and perhaps theirs, could be discharged to this lower level of residential care, as opposed to, I believe they're often going out of state to programs today because there is no PRTF level program in the state. So that reopening of that program that we had run for years up until the pandemic is really filling a major gap where those patients go out of state today. I think it remains to be seen, and we want to evaluate, working again with DMH and our partners at the state, that as those beds come online, is there something else we could do with that, with the inpatient space that we have, that would better suit maybe a different patient population? But we haven't had those conversations with DMH and our partners yet, but we certainly plan to, and I'm sure it's on their radar as well to talk about that.
Those are all the questions I have. Back to you, Chair Foster. Thank you.
Yep.
Thanks. Member Holmes?
Yeah, thank you. And thank you so much for the presentation, and congratulations, on reducing the wait times. I know that's really important, and also reducing the reliance on contract labor. Those are remarkable accomplishments in the last year. I have a couple quick questions in the interest of time. One was just about the revenue projections around Medicare Advantage. It looked like you were projecting growth in both inpatient and outpatient revenue coming from the Medicare Advantage plans. And given the departure of a lot of Medicare Advantage plans across the state, I'm wondering where that growth in revenue is coming from, if that's out of state or something else that you can speak to.
Jill, is that something you can address, or do we want to get back to them on that?
I think it would be best to get back to you on that one. Just let me do a quick analysis of exactly where that population is coming from. I can tell you it's not out of state. We don't take many patients from out of state, but we will get back to you on exactly what we think for that patient population.
Okay, that would be helpful. I also noticed there was a fairly large drop percentage-wise in out-of-state Medicaid, and I was wondering from revenue what that was driven by.
Sure. Oh, go ahead, Steve.
I'll jump in. I would say that to some degree, or actually to a big degree, that's New Hampshire. Their Medicaid rates are significantly lower and frankly well below our cost of care. And so as we have worked with them and had conversations with them, what they've asked us to do is to remain enrolled in their Medicaid program, but we would work to do single case agreements with them on patients that they really need us to take. They've been, working to expand their own internal capacity. But I think what's happening is that's a market dynamic where New Hampshire is trying to do more to take care of their own residents, if you will. But also their rates were so dramatically lower than our costs or what Vermont Medicaid pays that we agreed to move to this single case agreement. So we see less patients specifically on the inpatient side from them. But that's the big piece from that.
Okay, great. No, curious about that. Thank you for clarifying. Forgive me if I don't know if this is an obvious question, but is esketamine, is that a drug that would be administered outpatient and be subject to the 120% ASP drug cap? And how does that, if it is, how's that influencing your budget?
We don't think it's associated with that. With the act, I think it's Act 55.
Yeah.
However, I'm pretty comfortable, and as we put in our new electronic health record and so on, and have looked at charge masters and so on, in the spirit of that, we're going to essentially make sure that it is at not higher than 120%.
Okay.
But it's, as I say, it's the only drug that we administer on the outpatient side, so we're focused on that one pretty tightly.
Okay, thank you. And this one can be certainly for follow-up in the interest of time, but I did hope that you maybe perhaps in follow-up could address the quality of care, the hospital report card from April 25 that came out, particularly some of the performance on the preventative care and screening relative to national, and then the relatively high levels of restraint and seclusion use that seemed higher relative to national. So there's a couple of things that stood out to me. Happy to receive written kind of response to that in the interest of time, but what you see in it, if you're addressing it for the future, how you're addressing it would be really helpful. So
yeah, we can certainly produce that, and I think what you'll find in short is that there are some of those measures are relevant, and some of them, as you dig deeper into how it's measured, there's good reason why our metrics aren't at some of the levels other hospitals are, but Dr. Jeffries will be able to produce a written response on that for sure.
That would be fantastic. Thank you so much. That's it for me.
Thank you. Member Teachout.
Great, thank you. I don't have too many questions that haven't been covered. I did want to ask you specifically about the employee retention credit. What did it apply to all levels of your organization, including executives? And how do you plan on handling this in future years, or was it a one-time event?
So I can handle that. So we worked with our partners at Barry Dunn to put together the spreadsheets for the 3 quarters. I would have to get back to you on exactly whom it all covered. So we'll take that one back, and I'll make sure that I get that answer correct. But in terms of in the future, we don't anticipate credits like this to happen again. So we really are focused in 2026 and beyond on making a sustainable financial plan that includes things like our days cash on hand and other metrics that have been challenging for the retreat. In the past 5-6 years, we came from a very difficult position financially and have really worked hard at getting ourselves into a sustainable place. And we were fortunate this year that receiving those credits lined up with the EHR transformation, because that was a very expensive project that really needed to happen. And I think we're going to see some real solid financial gains, particularly in our revenue cycle functions from that technology. The previous system was difficult, to say the least, in terms of our revenue cycle.
Thank you. And does Barry Dunn also benchmark your executive salaries for you?
No, those are handled by our board.
Okay. And I think I had only one more thing I wanted to ask you about. The new service lines you're adding, specifically the outpatient and the expansion to the the center that has a woman's name. I can't remember what it's called right now.
Center Marsh.
Are those gonna change the mix of payer revenue? And will you have more commercial patients, or is it still gonna be predominantly Medicaid?
So we anticipate that the new residential program will be primarily Medicaid. We do see a little more commercial business in our outpatient book of business than we do in our inpatient. So it would be logical to think that as those programs come online and ramp up, through the middle of the year, that we might start seeing additional commercial in our payer mix.
Okay, great. Thank you. That's all I had.
Member Merman?
Yeah, maybe just following up on that question. I had a question about the intensive outpatient utilization forecast, starting at 60 patients and getting up to 350 visits a month. And I guess my question was, is there enough local demand for this? This kind of pretty substantial ramp up.
I can jump in on that just to say that, and Carl, please help me out here as well. But the projections we're making, because it's all telehealth, is that we're expecting that to be a service that's statewide. And frankly, I'd like to actually partner with schools as well, so that, for example, a child that might be participating as they integrate back into school could potentially have a space in the school where they could participate in those as well. So it's really meant to be a statewide program and not just down here in the Brattleboro or the Windham County area.
Okay, so that's entirely virtual.
Yes,
entirely.
Okay, and then the discharge follow-up clinic service, I guess, would that be entirely virtual as well?
Primarily, yes. We would have space available if there were people local and it made more sense for that, but it's primarily going to be virtual.
Okay, and my other questions are on the alternative payment method. So I'm a little bit, I'd like to learn a little bit more about this, but I understand that your contract with Medicaid, your bed census was to go from 51 to 56. Does that mean, what does that mean?
So the way this program works, of course, we have 100 beds, right? That we typically try to have 100 available every day. What we've done with the agreement with the state is that they pre-purchase 56 beds per day from us. So they send us a check once a month for the daily per diem rate for 56 beds every day. And what that does is it allows us to have revenue through the year on a consistent basis that allows us to then operate the business, if you will, because we have some very long lengths of stay as well. If we were to only get reimbursed at the end of these stays, we'd be waiting a long time for payment on some of these patients. So what that does is it helps us, and I think it helps the state in that they have a very straightforward budget plan for cash flow as well, so that we can care for a high number of patients from the state. And then we have guardrails so that if we overachieve that, they're going to pay us for some additional days. If we way underachieve it and they don't send us as many patients, we could potentially owe them some money. And this is the kind of agreement we've had. I think this is our 5th year now. And so in the initial years, we underperformed and we owed some money to the state. And in the last couple of years, at the end of the year, when we did the reconciliation, the state owed us some money because we had provided many more beds. They had used more than the 51 or the 56 they had paid for. The reason we bumped it from 51 to 56 was that the last 2 years, 23 and 24, the state significantly used more beds. And so, they owed us somewhere in the neighborhood of $6 to $8 or $9 million that had to be paid in a lump sum several months after the end of the year. So we were trying to right size it so that they didn't owe us a lot and we didn't owe them a lot at the end of the year. So it works really well for both of us, I think.
That's interesting.
I hope that helps.
It does help. And so with the 9% reduction per diem rate is essentially like a 9% roughly-ish increase in the contracted number. So it keeps that dollar amount probably even, I would assume then.
Well, I think it does. And the way they set the per diem rate is we submit, a lot of information about our cost of care, and then we negotiate that rate each year based on what our costs are. And so that rate had been going up for a few years, and then from 24 to 25, we agreed to lower that rate and see if we can make things work at the 28.25 per day that we're doing today. And so that is a negotiation that happens every year. That contract is actually going through the signature process as we speak for 2026, but we've agreed on the rate for the coming year at the same flat rate as we had last year.
So one concern I had when I first read this was that if you went from 51 to 56 patient beds census contracted with the state, could that incentivize you to increase your length of stay? If patients are staying longer, you fill more beds, but how do you avoid, how do we avoid that incentive, I guess?
Carl, do you want to talk about that? I mean, I think that, I'll just say briefly that, especially from the adult side, if you look at the ER tracker across the state, there's always adults waiting for a bed. And so we're trying to move patients out as quickly as we can, as soon as they're ready. And also, I don't think it's good for patients to hang around in an inpatient unit when they're ready to go. But I'm going to shut up and let the doctor talk for a minute.
Well, I would just say that we have daily utilization management meetings and review of each case to make sure that the patients continue to make level of care. And as Steve pointed out, clinically keeping patients beyond the time frame is often both harmful to the patient as well as to the milieu and the treatment environment for everyone else. And so we really do stay focused on getting people in and out as quickly as possible, knowing that there are patients in the ED that we are trying to bring in as well.
Thank you.
Okay, thank you. Any comments or questions from the healthcare advocate?
Thank you, Mr. Chair. No question, but I think I will take this opportunity to spend 30 seconds or so to just acknowledge, I want to acknowledge and appreciate your comment about uncompensated care and the work that is being done there, and to recognize due to some of the aspects of HR1, the twice annual redetermination and the work requirements starting in 27, that effort is going to need to be doubled. We're going to need more of those kinds of efforts. So appreciate your work in that.
Thank you. That's been a real team effort across the organization to do that. So we appreciate that.
Great. And I'll open up to public comment via raise the hand. Okay. Hearing none, Ms. Meschke, Mr. Cummings, and Dr. Jeffries, thank you very much for the presentation today. And we finished exactly on time. So we appreciate that very, very much.
Thank you for the opportunity.
Thank you.
Great, thank you. Okay, and we'll turn straight into the Rutland agenda item, and I'll turn it to Ms. Barabee, our Director of Policy here at the Green Mountain Care Board.
Thank you for having me. Can you all hear me? Okay.
Yes.
Okay, Abby, do you mind sharing the slides? Okay, I am Elena Barabee, the Director of Policy at the Board, and today we're going to hear from Rutland Regional Medical Center. They recently submitted our first notice of service reduction. So we can go to the next slide. So I'll just talk today a little bit about, very briefly on the background, just to remind folks of what the statute and the policy are, since this is our first time. All of these materials we have gone through at one point in time, so this shouldn't be new information, but because this is the first notice, we thought we would spend some time revisiting some of the key elements of the statute and policy. So Act 68 of 2025 requires hospitals to provide a notice of intent to the Green Mountain Care Board, AHS, and the Healthcare Advocate for any proposed reductions or eliminations of services. There is a 45-day kind of window with which hospitals must provide this, and they must explain the rationale for the proposed reduction. And I will talk more in detail about the policy that we've developed in order to implement this statutory mandate. So next slide, please. So at a high level, there's this 45 advance day notice. As I mentioned, the notices are sent to a variety of parties, including Green Mountain Care Board, Agency of Human Services, Office of the Healthcare Advocate, Department of Financial Regulation, and members of the General Assembly. The notice must include, per the policy, a description of the change, rationale, as well as alignment with the statewide healthcare delivery plan, which AHS has not yet developed, but is due in 2028, as well as community health needs assessment in the meantime. So there's also a requirement for a financial analysis, transition planning, and an estimated timeline for the change. So I'll go to the next slide. So as I mentioned, so the GMCB reviews these notices and evaluates whether the proposed service reduction is consistent with the statewide healthcare delivery plan. And as this hasn't been kind of fully developed, we've adopted an interim policy in the meantime to really kind of flesh out how we're going to look at this in absence of this plan. So another element that we're interested in kind of comparing to is the hospital's mission and vision. And as I mentioned before, the community health needs assessment. Part of the policy indicates that the board will have 10 days from the receipt of a complete and accurate submission to determine if a full submission is necessary. So that is an additional level of detail that we would request from hospitals to explain a variety of factors as noted in the policy related to the proposed reduction. If the board does not issue a written response within 10 days of receipt of the notice, the hospital may proceed with the proposed reduction or elimination. So you can go to the next slide. The full submission entails an impact analysis, alternatives that have been considered in lieu of the proposed reduction, an updated financial analysis, and any other information that may be necessary to evaluating the proposed reduction. This will also include a special public comment period, public hearing, perhaps a request for additional input, and review of other information. Next slide. In evaluating the materials that are submitted along with the proposal, so again, the consistency with the statewide health or delivery plan, again, we don't have that. The community health needs assessment is what the statute points to in lieu of this plan. And the policy points to the impact on access to care for patients, the quality of a transition plan, impact on population health and quality of care, affordability and cost, hospital financial sustainability, and really the broader system-wide impacts of this proposed change. Go to the next slide. So I wanted to give you kind of an outline of where we are and what has happened leading up to this today's hearing. So Rutland Regional Medical Center submitted their notice on October 30th. At first, the Green Mountain Care Board determined the submission was incomplete and requested additional information. That all happened relatively quickly, and then determined that the policy applied to the proposed reduction. Then we requested that Rutland Regional Medical Center file the full submission, so all of the available or all of the requested information that we lined out previously. That was delivered and reviewed, and today we've scheduled, this is our first hearing on the topic. We have scheduled for December 10th, staff analysis, possible recommendation and vote, and then kind of another deliberation and potential vote for the 17th should more time be necessary to collect information or provide additional analysis for your deliberation and decision making. So the deadline for the board based on the statute to decide to take action or not is really December 20th. Go to the next slide. So next steps, we've received already several hundred public comments, so we can continue to receive public comment. As I mentioned, the staff analysis is going to be teed up for December 10th, and then a potential vote or a subsequent potential vote if more time is needed on the 17th. And that concludes the staff presentation. I'm happy to answer any questions you may have before we hear from Rutland.
Great. Thank you very much, Ms. Barabee. Ms. Fox, are you and your team here?
I have a full team anticipating there'll be numerous questions. I wanted to make sure we had the opportunity to have the right people in the room to respond.
Great, thank you. So I'll have Mr. Hanksler swear in you and your colleagues, and then we'll turn it over to you for any presentation or comments you'd like to make.
Perfect.
Hi, everybody from Rutland Regional. So I'm going to administer the affirmation. What I'll ask you to do, similar to what we just did with the retreat, is have each person who is planning on testifying or potentially testifying, please state your name for the record individually and affirm the oath. And that way we have everybody's names clearly on the record. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
This is Judy Fox. I do.
Kelly Watson, I do.
Philip Lapp, I do.
Jen Bertrand, I do.
Laura Galster, I do.
Mitchell Baruti, I do.
Sheena Fisher, I do. Allison Davis, I do.
Thank you. Witnesses are sworn in. I'll turn it to Rutland Regional.
So I want to begin by thanking the Green Mountain Care Board for their time today and allowing us to present our findings and how we came to the conclusion for this change in delivery of pediatric care. We do have a short presentation that we will be working from this afternoon. So if you don't mind, we will share our screen, and Melissa Belko will be providing facilitation for us. Thank you. So as I understand it, we've got about 30 minutes to provide this material, and then we will be ready for questions. So as we begin, just wanted to kind of set the stage as an executive summary for how we arrived at this decision, and some of the research and work that we've done to come to this decision. So we are proposing a transition in inpatient pediatric care, and we're doing this to align with what we see as evolving needs in our community. And quite frankly, we're seeing an aging community and less demand from children in pediatrics. I want to be very clear with the Green Mountain Care Board, though, that this decision is driven by quality. While it supports numerous financial and affordability goals, both here at the hospital and at the state level, it was really driven by quality. And as we looked at the declining birth rates, an aging population, low pediatric census, our reliance on travelers, and our inability to recruit to the unit, as well as continued financial pressures and our commitment to the state and how we align with state goals to regionalize and transform services. But to be very clear, while we are suggesting that we discontinue our inpatient pediatric unit, we are not suggesting that we don't provide care to our pediatrics. In fact, it's quite the opposite. We're working hard to reimagine care pathways to keep as many of those patients here in our community, in our hospital as possible. And you're going to hear from the team as to the work that's happening there. So in short, this proposal is to eliminate our inpatient pediatric unit with a full commitment to redesign care for neonates, for our pediatric children, both in the unit and our emergency room, our carry-out services, and then ways in which we can increase our ability to care for adolescents in our community. All of this work will also be enhanced by transfer protocols and partnerships that we have now today with our tertiary medical centers. And so I know it's important that we understand how this project aligns with state initiatives. And although there's a bit of timing in terms of state protocol and structure, we have looked at the work of AHS, particularly around regionalization and transformation services. And while I don't want to read everything on the slide, I think those bolded blue components really speak to the alignment of this very difficult decision that we have made here in our organization in alignment with state initiatives. So it does address cost sustainability, workforce, strategic regionalization, really mirrors population needs. And we did use our community health needs assessment to inform this decision. We are committing to retaining as much service as we can. We have, and we'll hear Dr. Lapp talk about how we've increased care coordination and providing some outpatient services, again, aligned with our community needs assessments. Slide, please. I think it's really important for the board to understand that this was not a quick or haphazard decision. This is a decision that has taken some time. And honestly, to use a framework and use a framework for this decision that we've had in place at Rutland Regional for about 3 years now. This is our strategic planning framework. And what this framework does is ensure that we're looking at all aspects of care redesign or care decisions here in our community. We look at community need, our clinical forecast, our quality care, what the impact is on operations and finances, and then very clear to understand what success looks like and adopting metrics that will help us understand and be accountable to decisions we're making. I also want to be clear that this strategic decision framework has been in use for a while. And as an example, last year we were focused on our ophthalmology and our eye care services, thinking that that may be a program that we should look to redesign or make a decision on. After completing this framework and understanding clinical forecast and quality need and understanding opportunities for efficiencies, we came to a very different conclusion. Unfortunately, for our pediatric program, the model really substantiates and justifies our position. So I'd like to get into the meat of this decision-making now and ask the Rutland team to begin to talk about each of these pillars within our decision-making framework. To start out, we'll talk about our community need, and Kelly Watson and Dr. Philip Lapp will run you through how we came to inform ourselves about it.
Thank you, Judy. So currently we provide inpatient pediatric care within a small section of our women's and children's unit. This unit is a combination of pediatrics, postpartum and newborn couplet care, and on occasion, select post-surgical patients. We also care for a small population of adolescent patients in other departments throughout the hospital, like our ICU, our surgical care unit, and our progressive care unit. Each of those units have different criteria that allows for a limited number of adolescent patients to be seen. Of the 250 total pediatric patients that we saw inpatient in FY25, 237 of them were cared for on that dedicated pediatric unit within women's and children's. Most of the pediatric stays were less than 24 hours. And the vast majority fell into that low or very low acuity, meaning that the 92% of those patients on the unit had the least intensive or less intensive medical needs.
Sorry, do you mind if I
data
interrupt for one?
shows-
Sorry, let me interrupt for 1 second. Would it be possible to turn a camera on? It just kind of helps to see the speaker if that's possible.
Oh, sure. My camera is on. I can, my camera is on.
Okay, it looks like it's all coming through is it Felkel's audio?
If you right click, you may be able to spot.
I'm not sure how to change that. I'm sorry. My camera is on though.
Okay, all right. Well, don't worry about it. If it's tricky to get. Sorry to interrupt. Thank you.
No, fine. Sorry about that. So our data shows that our inpatient pediatric beds are largely unoccupied throughout the year. 169 days out of the year, we actually had 0 patients on the unit at midnight, and 112 days out of the year, there was only 1. This graph here shows 2 years worth of average daily census data. With the majority of the time, we averaged less than 1 patient per day. The community need for inpatient pediatrics has declined, and it's projected to further decrease in the coming years. I also want to point out that this past July, we actually went 16 days in a row without a single pediatric patient on our unit. Dr. Lapp?
Thank you. The Community Health Needs Assessment is an important tool we use for prioritizing the allocation of resources. And the bar graphs here show that Rutland County is an aging community with significant declines, and that is associated with a decrease in the birth rate. You can see a significant drop in the overall population from 2020 to 2025 and predicted to continue into 2040. And the decrease is all within the age group less than 65, while at the same time, the number of people in our community over the age of 65 has grown and is predicted to continue growing. Specific pediatric needs that were identified through the Community Health Needs Assessment included issues related to high rates of social drivers impacting utilization of care, the need for mental health services in this population, and limited access to therapies, including speech and language pathology care. We have made investments to try and meet these needs, and in our women's health service in 2023, we hired our first nurse midwife to meet community desire for those services and expand care offerings for families. In 2024, we added 2 new full-time OBGYN physicians to that service line as well. In 2023, we also hired our first dedicated pediatric speech and language pathologist to help meet some of those identified needs from the Community Health Needs Assessment. And you can see that there's been a significant utilization of those services already. Within our emergency department, from 2022 to 2023, we participated in a pilot project to expand access for mental health services by utilizing telehealth technology in partnership with the Brattleboro Retreat. That's a service we continue to offer today. And we were pleased to receive a Pediatric Readiness Innovator Award in response to several focused improvement projects within the emergency department, where we see over 3,500 or so pediatric visits per year. In regards to some of the social determinants of health, we also have allocated 3 FTEs dedicated to support pediatric care within our community health team. and they review every pediatric visit to the emergency department and engage with about 480 patients quarterly. Having reviewed some of the community needs that factored in her decision, we'll now transition to review some of the data we considered in the clinical forecasting and quality of care. This graph shows national trends in pediatric utilization, and you can see that there's been a 28.9% decline in pediatric hospitalizations nationally, with an expected further 9% decrease over the next decade at non-children hospitals. And you can see that the decline is predicted to be especially notable in the very low and low acuity cases, which make up 92% of inpatient volume at our hospital for pediatric patients. And those are the two light yellow lines at the bottom of the graph. Vermont trends have mirrored national trends. There's been an overall 10% decline in pediatric discharges between 2016 and 2024, and an even sharper 22% decline in inpatient stays, excluding the lower acuity observation stays during that time period. Here at RRMC, we have seen a similar pattern, and the declines in volume have been 48% reduction in pediatric cases in the hospital from 2003 through 2025, with sharp decreases in both inpatient discharges as well as observation discharges.
Infrequent pediatric admissions limits staff exposure to caring for this specialty patient population. Contract and employed staff have commented that gaining competencies and retaining skills can be a challenge without frequent practice. Over the past few years, this shared concern for maintaining clinical competency has been expressed by those involved in Vermont's care transformation efforts. And we've provided a few of those quotes related to potential risks between quality and low volume on the slide for your review. Low volume and infrequent use of clinical competencies poses a quality risk, but it also challenges us with recruitment and retention of pediatric specialty nurses. Our proposed redesign supports a more sustainable model. Our ED sees between 3,500 and 4,000 pediatric patients a year. So the care teams in the ED care for this specialty population on a daily basis. We've recently been recognized for our high quality care delivery for pediatrics in the ED with the Pediatric Readiness Innovator Award. We're very proud of that recognition, and I know Dr. Lapp had just mentioned that as well. Moving on in our framework is our operational model. So I'll go over this and I will share this with Dr. Davis. So in an effort to keep as many pediatric patients as we can at Rutland Regional Medical Center, we have stood up or established a pediatric care delivery committee. This is co-chaired by myself and Dr. Lapp. It's a multidisciplinary group, and we're really focused on the care pathways that are listed there with our neonates, emergency pediatric care, perioperative pediatric care, adolescents, and working with outside facilities for those that may require transfer. So just to get in a slightly more detail about those pathways, again, the goal is to try to retain as many pediatric patients within our community as possible. And so within our emergency department, we want to continue to provide that nearly 4,000 pediatric patient volume, and then enhance how we provide care for extended length of stay if needed. We also want to focus our resources on that couplet care and neonates around the 28 to 30-day old period. We're also looking at our adolescent practices. We currently have a policy in place in our ICU to care for 15-year-olds and up. And we're looking at our surgical care unit and our progressive care unit to see what opportunities we have to expand that adolescent care. We want to continue to work with our pediatricians to ensure that management of care and consults continue to be in place. We're looking at working with our surgical partners at how we maintain as much pediatric surgical volume as we can. And as I mentioned, looking to enhance our partnerships with tertiary care centers to support pediatric patients and their families who may need transfer. This next slide kind of breaks down the numbers from fiscal year 25. Again, our goal is to try to keep as many pediatric patients as we can in this care redesign. In fiscal year 25, we had to transfer 15 pediatric patients to other facilities. We anticipate that would remain the practice. There were 11 neonates who were readmitted in fiscal year 25, and our goal would be to retain that newborn population as mentioned. Again, with the adolescent population, it's our goal to reassess current practice so that we can maintain that volume within our facility. And looking at that less than 24-hour length of stay and how we work with our emergency department to ensure care for those patients so that they can remain here within our community close to home. So it really leaves about 60 to 80 patients that we may be able to keep here in our facility, or that we may have to work with our tertiary care facilities to transfer.
Thank you, Kelly. I'm Allison Davis. I'm the medical director of the emergency department. We are committed to ensuring our ED is as safe and calm and therapeutic as possible. All of our rooms have doors and centralized monitoring to allow us to track oxygen level, heart rate, and blood pressure, among other vital signs. Some rooms have private bathrooms, other rooms have glass walls to maximize visibility for nursing and providers. Right now, when we keep a patient for a longer ED stay, whatever the reason, we always consider what the patient needs most and place them in the most appropriate private room. We have cribs and recliners available for parents and small children, and we are exploring other ways to make our spaces more child-friendly. Patient and staff safety is a high priority. We are fortunate to have a locked unit in the emergency department for patients with acute psychiatric needs or dysregulated behavior. Our triage process facilitates immediate placement of these patients to ensure safety in our waiting room and in our general ED. In the past 2 years, we have operationalized weapons screening for all patients and visitors to the ED. We have also rolled out training in de-escalation to all staff, which has dramatically reduced the number of times our security staff need to physically intervene with patients. Turning to the question of patients who require transfer, again, we currently transfer approximately 74 pediatric patients annually. These represent the sickest children in our community who are stabilized in our emergency department and transferred to a higher level of care. Anticipating the need for additional transfers with this service redesign, RRMC engaged with UVM to establish a formal transfer agreement for pediatric patients and is exploring similar agreements with other tertiary care centers. We are actively working with our local EMS agencies to ensure they have the training and equipment to handle additional transfers, recognizing that they currently transfer many of our sickest pediatric patients. Given our current transfer patterns, the additional transport capacity required would be for lower acuity patients. Transport options are typically more widely available for this cohort of patients. Statewide efforts to regionalize healthcare will require additional transport capacity for patients of all ages, and RRMC continues to engage in the conversations on this key aspect of healthcare transformation. And now I'll turn it over to Jen Bertrand for the financial section.
Thank you, Allison, and good afternoon. For the financial portion of our presentation, I'm going to be brief because this is predominantly a clinical, quality-related, and competency-driven initiative with a bit of a financial component to it. So from a cost of care perspective, transitioning patients to the emergency department setting certainly can have a cost of care benefit to it, largely because patients would not be subject to an inpatient room charge. And of the 250 encounters in 2025, 64% were inpatient stays. And of those 159 inpatient stays, when you exclude any stay types that may be treated in another care setting within our facility or transferred to another facility, approximately 76% of the 159 inpatient stays represent room charges that could be avoided, which results in a total cost of care savings. And as you can see from the chart on the slide there, we've estimated that savings to be approximately $229,000. To highlight the financial impact of this care delivery redesign, the 9-month impact would be a savings of $2.3 million. And this is primarily driven by salary savings. And that annualized savings would be approximately $3.1 million. And then for the subsequent 3-year period, we are estimating a cost savings of approximately $7.7 million. And lastly, from a financial perspective, with this particular slide, there's a potential capital savings over a 3-year period of $4.1 million as well. From a staffing perspective, the redesign of this service will consolidate staffing across 3 units, which will result in a decrease of FTEs from 27 to 14. We certainly cannot emphasize enough how committed we are to ensuring that we can retain any impacted employees that are affected by this redesign. We have many other employment opportunities within our organization, and as much as we appreciate and the support that our current RN travelers provide to our organization, it is our goal to replace those positions with the impacted RNs from this transition. Additionally, for those impacted LNAs, we have 12.3 open FTE positions that we hope they will take advantage of within the organization. And as an incentive, we have offered transition bonuses to those LNAs in the hopes that they take another position within the organization. I think that does conclude the financial portion, and I'll turn it over to Judy for final thoughts.
Yes, thank you for the time. Just summarizing what you heard today. So as we consider changing our pediatric care delivery model, we want you to know that it was informed by state, national, and RRMC data. And we're very disciplined in how we use this data. It does respond to the ongoing decline in patient demand and the risk of low volume programs and that risk as it relates to quality care. We are challenged in retaining and recruiting staff to this unit, so it does support that challenge and mitigates that somewhat. We remain committed to care delivery transitions. We remain committed to keeping as many patients in our community here as possible. We do extend resources for families who require transfer, whether that's help financially or through enhanced care coordination. We are looking to prevent any reduction in workforce by facilitating those intra-organizational opportunities that Jen just discussed. And we do believe that this fulfills our responsibility to engage in transformation and regionalization efforts in partnership with the state. So this does conclude the formal presentation that we prepared for you today.
Thank you very much. This is our first review of a notice of service line reduction, and I appreciated your team working with ours to make sure we had all the information we needed and for the presentation. So thanks for the effort that you put in so that we could do this work. I'll start with board questions, and we'll start with Dr. Merman.
Hi, thanks. We can't see you, so I'm just going off your voices, but a few quick questions from the presentation, then I have some more prepared one. But you mentioned you're working with the ambulance services I believe, kind of to determine the capacity for their ability to transfer these patients. How have these conversations gone? Where are you with this process? Do you have any information on their ability to transfer additional pediatric patients?
Sure. So I will let Sheena Fisher, our Director of Nursing Services, who works with ambulance services, to respond.
Good afternoon. Thank you, Judy. In talking with Mike Tarbell, the CEO of Regional Ambulance, we have looked at the data. We've looked at the number of transfers, the days of the week, and the hours of transfer that we have been transferring patients. And we are working collaboratively to increase staffing during those times and days of week to ensure that we have the staff and the resources necessary to get these patients to the tertiary care centers in a timely fashion. We have also increased our staffing here at Rutland Regional in our emergency department and float pool to include paramedics for the cases that we need to put that person on the ambulance service to help get them to the tertiary care center as well. So using our resources in-house, as well as our partnership with Regional Ambulance and other local ambulance services, and making data-driven decisions to improve staffing and access to transport.
Okay, so working together, collaborating to try to increase staffing, you're about to hit the peak season of the year that would need pediatric admissions, right, as this redesigned program's being rolled out. Are you ready to go with it? Do we have increased staffing ready to go December 21st?
Yes, as of December 6th, we have a paramedic on staff in our emergency department 4 days a week from the hours of 11 a.m. to 11 p.m., which we have, the data has shown that we have the increased amount of transfers during that time.
And that paramedic, I guess the question is, do you have trucks and people to get the kids safely from Rutland to UVM?
Yes, as you know, the basic crew is something that we have access to. It's when we need a higher level of transport care that we've been having trouble getting kids out with. We still are working through these challenges. It's an active process, but we are working, like I said, collaboratively and have the additional resources now 4 days a week.
Okay. And the other thing that came up, I just wanted to clarify from the presentation that your total cost of care savings calculation is the calculation that's based upon the room charges, comparing the inpatient charges to the ED charges. That's how you're viewing this as a total cost of care reduction?
Yes. Yes.
Okay. You talking about the transition plan and quality, you mentioned in the narrative that you worked with clinical experts on your redesign plan. Who were the clinical experts?
Kelly, do you want to take that?
Oh, sure. So this is a multidisciplinary group. We've worked with pediatricians, our ED providers, nursing staff, respiratory, our surgeons. So we've been looking at this from a multidisciplinary lens.
Okay, we received public comment earlier, in-person public comment, well, virtual public comment, that the pediatricians were not involved in this process and found out when it was rolled out. Were there pediatricians involved in the clinical redesign process that work with kids at Rutland?
So the decision was made as a hospital decision, knowing that as we were moving forward with redesign, that it would require broad stakeholder involvement, including our pediatricians. And so it has always been our intent that those individuals, as well as many others within our facility, would need to be involved in care redesign.
Okay. So the decision was made, and then the pediatricians were involved in how to implement this process. Is that what you're saying?
Yes, that was the plan.
Regarding quality as well, as you know, I work in an emergency department, and I am a physician, so I've read through quality literature for a lot of my career. Is there specific data that you can provide that addresses these low to very low acuity admissions being, you know, the risk of volume and quality and these low to very low acuity admissions?
So I'll ask Kelly and Dr. Davis to take this question.
Sure. So we have seen that with infrequent use of clinical skills that it can put you at risk for not being prepared to take care of a specialty population. Whereas, you know, in our emergency department, it's a daily skill set that's practiced and the readiness that is there. So that factored into the quality component of this. We have had times where trying to onboard and train staff into a specialty area like pediatrics, where you have infrequent volume, you can make it very challenging to get those competencies that you need within a short period of time because there's a lack of volume there.
Okay, but no specific data that looks at the volume quality relationship within these lower acuity pediatric admissions that you know. You're talking about generalized skill and those complexities. I understand that, but just it was a lot of discussion about the volume quality relationship, and I just wanted to see if there was specific data related to this population that I was not aware of.
No, with projected decreased volume lower than what we already have, it's more around the risk that there'll be less frequent opportunity to practice those skills and maintain competencies.
So Al, I'm sure you're aware of the length of stay argument within emergency medicine. There's pretty extensive literature on the quality, you know, poor outcome risk of patients who have long length of stay in emergency departments. So I'm just trying to understand if you were to, how do you balance that risk with the risk that you're discussing here?
So I think that when I think about it, we're looking at a patient population that could be cared for in what would be called an ED, extended care unit, at like a larger academic pediatric institution. So we're not looking to maintain an inpatient level of care for pediatric patients. It's more that those patients with a lower acuity, lower need for interventions, and anticipated relatively quick turnaround time, for lack of a better word, would be that those would be the patients that we would be looking to keep in the emergency department. So we're not opening an inpatient unit in the ED. I think that most of the literature around boarding and issues with poor outcomes with boarding are when you have higher acuity patients who are unable to get an inpatient bed and end up having extended ED stays. But that's not the patient population that we're talking about in this case, if I'm understanding your question correctly.
I think we're talking about the same sort of concept. But I guess one of the challenges of working in the emergency department is that you know, there's this constant need to prioritize what's most urgent, and often patients that are boarding, even lower acuity patients who have routine treatments that are needed. Say we're talking about a asthmatic kid would be the classic example of, I think, something we're talking about. Then, you know, the NEB may not happen when it happens because you're dealing with the respiratory failure patient or the trauma patient or the dysregulated patient. So are you thinking about staffing differently in order to manage longer boarding patients, especially in these higher volume months like January, February, March?
Yeah, I think you can appreciate that, there's unfortunately no crystal ball for what's going to come in on any given day in the emergency department. But, our overall volume, we're staffed to see 90 to 100 patients a day. When you look at what the average daily census is, we're talking about, on average, again, 2 or 3 patients, potentially. Oftentimes, it would be 0 patients. And so, as with any influx of patients into the emergency department, whether it's from flu season, whether it's from a Spartan race at Killington or a national downhill mountain biking event, we see surges in the emergency department, and we respond to that by relying on our float pool, calling in extra physicians, calling in extra nurses. If we see a sustained pattern, then we look to change our staffing. As the numbers bear out, it doesn't seem like there would need to be a significant shift in terms of provider staffing. Sheena has already spoken to changes in terms of nursing staffing that they're looking at. Again, we try to be flexible. We try to respond to the need that's in front of us. But as we see trends, we look to modify our staffing and respond appropriately.
Addie, can you pull up the slide that they have there's a spreadsheet at the end of the full submission that kind of goes through some of the finances. I'd love to walk through this a little bit because I have some questions about this. So when I look at this, in the far most left column, it has 106 for net patient service revenue has $169,000, $170,000. Does that seem right for the current year 12-month NPR?
Bear with me. I'm going to pull it up on my screen, Dr. Merman, just because those are a little bit small numbers for me at the moment.
Okay.
You're referencing the NPSR data for the current year 12-month period?
Yep.
Yes.
Okay. And when I look at I call this sort of like my way of sort of estimating, when I look at the ratio of the net patient revenue of Medicaid to the gross revenue of Medicaid and the net patient revenue from commercial to the gross revenue of commercial, it looks the same, roughly, which makes me think that commercial's paying the same as Medicaid. Is that correct? You're paying about the same reimbursements for both Medicaid and commercial?
Well, we would use a blended rate for our estimates, just so that we're clear for the entire department as we look at that. So if you say our total effective collection rate for that service line is 30%, let's say, then we would apply that 30%.
Okay, so I get like about 36%. So is that about the same effective collection rate for Medicaid and commercial? Does that mean
that's blended? Yes.
Oh, explain to me the blended. I'm sorry.
So when we look at a particular service line, we will take the blended rate, the effective collection rate so we'll take, let's say Medicaid is a 17% reimbursement from an effective collection rate perspective, and commercial could be 50%. When you blend the two, you get to the 36%, if that makes sense. And that's how we would apply it to that service line.
I apologize. This is the court reporter. I know you don't have your video on there. Can I have the name of the person who's been speaking on Rutland's end there?
Certainly. This is Jen Bertrand, Chief Financial Officer.
Thank you.
It's a weighted percent, if that's helpful.
So maybe I'll just ask more straightforward. Are your commercial reimbursements and your Medicaid reimbursements roughly the same for your pediatric admissions?
No.
And how are they different?
Our reimbursement is going to be based on the percent of, so for example, if Medicaid is going to reimburse on every dollar, roughly $20 or 20 cents on every dollar, that would be our Medicaid ratio. Then on our commercial ratio, that could look differently. It could be 75 cents on that dollar. When you
Okay.
look at the payer mix across both of them and you weight that, it erodes your total blended collection rate down to that roughly 30%, 36%.
Okay. So when you look at the commercial net NPSR line there, $46,893, and the commercial gross, and you take that ratio, does that give me the collection rate on commercial for pediatric inpatient hospitalizations?
I'd have to look at my spreadsheet to calculate that.
So this is, as Jen is saying, this is a weighted average of blended. If you wanted us to provide data at the looking at gross patient service revenue and net patient service revenue at the payer level, that's not included in our current submission. That would be something we would have to provide after that.
Okay, I may need more clarification on what is blending in the commercial line, because I don't think you're blending Medicaid into the commercial, right?
Correct, but we're using an overarching weighted percentage.
Well, how about this? Regardless, you got $170,000 in revenue for 200 admissions, which is like $680 an admission, which seems remarkably low to me. Is that an accurate number, roughly speaking, then? Blending Medicaid and commercial together?
Yes, I would say that I could say that it's relatively low, considering we have about 72% of Medicaid payer mix on this particular unit.
Yeah.
Which, as you know, is reimbursing less than the cost.
Well,
and like state would play into that piece as well.
And your commercial revenue is $47,000 roughly on that unit for that year as well, right?
Say that again.
It says here your commercial revenue is $46,893.
Correct.
For that. Is that right? And I forget the number. It was in here, the percentage of the number of the commercial admissions, or at least the percentage of the total, but it wasn't, it was something like.
It's about 27%, if I recall off the top of my head.
250, so like about 75 or so admissions. So then you're still getting 75 admissions, $46,893 divided by 75 admissions gets you about $600-700 an admission or so. That seems like a very low commercial reimbursement for an inpatient service. Is that
like, again, we're using a blended rate. If we want to get discrete, we would have to go back into the data and we'd have to extract that exact reimbursement rate for that 27% of that particular population instead of a blended rate over the total.
Right. So I'd really appreciate the clarification, because the way I would look at this is I think you're saying that you have about $47,000 of commercial revenue, and you've said about how many commercial patients you have. So a simple average admission revenue would be easy to determine. And I think that what my point on all of that is that's a really low rate, a really low amount of commercial revenue for the amount of commercial patients that you're seeing, comparative, say, to a CT scan or an MRI or something else like that. And what I would like to know is what have you done with the commercial payers over the last decade while you've had low commercial volume and low revenue to increase commercial reimbursement for your inpatient pediatric service?
Well, we can get the detailed information for you. Again, we didn't separate it to the level that you're looking for, but we can certainly provide that. And keep in mind that from a commercial perspective, if the acuity is going to be low also, then there could be a component of that based on the reimbursement rate for those lower acuity CPT codes that we may be assigning for that unit.
Okay, but how about efforts made to try to increase commercial reimbursement rates over the last decade?
Room rates in general, we try to be cautious of what over the last couple of years, when we submit our budget, what our commercial rate requests have been. They've been relatively low. There was one year where we had a higher reimbursement rate, and we may not apply that solely to the inpatient side of the equation, but I can also grab that data for you if you'd like.
That would be helpful.
Okay.
Have you worked with Medicaid at all to try to increase reimbursements from Medicaid?
We certainly try to have those conversations, but Medicaid doesn't generally change their rates for us very often at all, and to hospitals in general.
Okay. So also looking at this, so we attribute $170,000 of revenue, but $5 million of expenses. So I guess I'd like to understand that attributes to 28 FTE, but I think the revenue of the 170,000 is really only related to the 13 FTE. So I think this negative operating margin of 4.5 million, is that reflective of the actual revenue that's coming in associated with those labor expenses, non-total expenses?
So those are the total expenses for the unit. That'll include labor. That includes permanent staff, contracted staff, and then, the revenue coming in is just based on patient volumes.
So when you say the unit, what do you mean by the unit, I guess? Is that the women and children's unit or the pediatric specific 5?
That existing model is the combined units.
Okay. So we don't see the revenue associated with labor and delivery, peripartum care, and neonatal care on this chart, correct?
Correct.
Okay, that's more helpful. I'm a little bit. Go ahead.
Oh, sorry. And as you can imagine, when you're looking at a cost to net revenue ratio here, it does demonstrate the inefficiency that we are seeing within the unit.
But you're not including the revenue, all of the revenue in this chart associated with all of these expenses. Is that right?
Let me just double check on that.
Well, you have 170,000 revenue, which is, I think, related to your inpatient pediatrics, but your total expenses are related to your entire women's and children's unit, which includes obstetric care, neonatal care, postpartum care, I think you just said.
Yeah, that would be accurate, actually, as I'm looking at that, yes.
And then what about, we received several public comments about other patients are cared for in this unit, post-operative patients or other patients that can be cared for. Do we have the revenue associated with that care?
Those are good. That revenue is going to be discrete to that other unit.
But
this is Judy Fox. I'll add to that. Back a couple of years ago, we had the need to place particularly surgical patients who were recovering on our women and children's unit. But as we are now with our inpatient census, we don't have the need to transfer patients off from a medical or surgical unit and place them in the women and children's unit because we had ample bed capacity in the existing units. So that was done as a way to help manage our census and our bed capacity.
Okay, so now you have other units that are staffed that can take the patients that you mentioned, the post-surgical patients. And then in the pediatric unit, you've got staffing, but you don't need to put the patient there because you've chosen to staff somewhere else. Is that fair to say?
Yes, they're staffing, they're placed in the unit that's appropriate for their medical care. When we don't have a bed constraint issue, that's the medical decision.
In the narrative, there's discussions. So in this worksheet, it looks like a roughly $6 million operating loss. In the narrative, you discussed the $3.1 million is savings next year, but then you also discussed that you would have a loss of $537,000 if you were to continue providing pediatric care. So I guess I'm trying to understand, is it a $4.6 million loss, or is it a $537,000 loss and a $3.1 million savings? Is that coming from a lot of other things other than just eliminating these 5 beds, or is that, help me understand those 3 different numbers.
Sure. So and Jen, I'll ask you to chime in. So the $500,000 loss, that's specific just to our pediatric revenue and expenses associated with that. When you look at the larger savings, it relates to being able to minimize staffing based on census across the 3 units.
And keep in mind that the 3.1 is for 1 full year of the impact of the savings on the unit. And that's what we tried to demonstrate here. Obviously we may look at this a little differently when we try to give you the more detailed information, but that's the impact. And that 2.3 million is the impact for the 9 months. The revenue numbers that you're seeing here in the impact is for the 9 months on that far right section. If you look at that for the year, that's where I believe the 558 was that you may be quoting.
I'm sorry, the 537 is where on this worksheet?
Hold on 1 second. Let me trying to tie back to the 558. So we may need to get back to you on that so that we can walk you through, crosswalk you through that.
Yeah,
map.
I'm sorry for taking so much time too. I just have a few more. We can stay on this sheet, which I think is really helpful actually. So you talk about like a heavy reliance on contract labor, but I see $391,000 for temporary staff expense, which I'm assuming that's 1 FTE RN for the year. Is that accurate?
Approximately. It's actually 1.5.
Okay, so the heavy reliance is 1.5 of 9. And what's your overall percentage of contract labor?
Current state for for combined unit, we have 5 contract labor. That would be all 3 units that we're talking about. For the pediatric unit itself, we have 0 up until last month. So now we're operating with 0 travelers on that particular unit.
Okay. So 0 travelers on the pediatric unit.
As of up until last month.
Okay.
But it's
so
a combined unit, so there's still in
total for the combined 3 units, we still have 5 travelers.
Right, but I think that, I guess what I feel like we're here today to talk about the 5-bed pediatric subunit within the WACU unit, which I'm trying to visualize, but it sounds like it's contained within in the similar space as the rest of the women's and children's unit is this 5-bed pediatric unit. But I think we're talking about the 5-bed unit, which you're saying at this point has no contract labor.
Correct.
Just recently, but we still have current state where we have gaps in coverage and we're unable to admit a pediatric patient or observe a pediatric patient because there's no staff available.
Sorry, let me interrupt. So witnesses need to say their names because we can't see you, and the court reporter has to identify the speaker. So I believe it was Miss Bertrand before, and just going forward, if you jump in, please just say your name for the court reporter.
Sure, that last comment was from Kelly Watson.
Thank you.
Abby, you can take this down. Thank you so much for putting it up. Okay, we also had some public comment discussing how kids are often direct admitted to pediatrics. Does this happen where a kid can get admitted directly to pediatrics without having to go through the ER?
Correct.
And when this happens, then do they only get the charge as being an inpatient or observation patient and not the ED charge?
That is correct. If they don't receive emergency care services, there are no applicable charges that would be generated in the ED.
Okay. And
that's Judy Fox.
Thank you. Sorry. I know your voice well, but the court reporter does not. So sorry. So have you, when I think about total cost of care to the system, I'm thinking about what's the cost that's going to be had for a patient who previously could get maybe a direct admit or to the pediatric unit versus now coming to the ED, getting an ED charge, then being transferred, getting a transfer charge, going to the ED at UVM because UVM most often does not direct admit kids. They want to see them in the ER. So they're going to get an ED charge at UVM, and then they're going to get an inpatient charge in an academic medical center, which I think would likely be higher than a community hospital. That's typical, and your commercial reimbursement looks fairly low. So I'm assuming it's the case, but I don't have that information. Have you calculated out those costs within this?
We did take
redesign model?
We did take that into consideration when we did that total cost of care calculation.
Okay, but I thought the total cost of care calculation you did was charges of inpatient rooms versus charges in the ED at Rutland.
Yes, but that is only 76% of those inpatient stays. So when you remove, so the total inpatient stays are 159. In our total cost of care calculation, you'll see 121. And that 121 difference between the ED room charge versus the inpatient room charge stay, we did it as a bundled calculation, estimated, of course. That's what we took into consideration. So those that would be direct admits, we did take that into consideration, a percentage of those when we did the calculation.
Okay, but how does that calculation reflect the impact to, say, maybe those 85 patients that are being transferred, or even those patients that previously were like direct admitted who are now ED obsing that whole time and now get an ED charge instead of a admission charge? But how does it take into account not just the charge, the actual cost to patients, payers, Vermonters, the system of the Rutland ED, the ambulance, the UVM ED, and the UVM charge, the UVM reimbursement?
We were just looking at it from those patients that would have received a room charge for us compared to that transitioning to a savings to the ED charge for the total visit of their stay. We would need to calculate some of the components of what you just described.
Okay. And then you mentioned this with elimination of the service could reduce direct costs to patients and families, but then again, it's the same thing. They got the ED, they got the transportation, they're going to an academic medical center, and then they have hotels, their transportation, missed work. So I don't know how we could, how do you justify this being reduced direct costs incurred by patients and families?
Well, most would stay in the ED. So
hi,
that's our
Kelly Watson.
goal, is to maintain them in RED so that they're not incurring that shifting of cost. For the 121 that we were calculating, they would stay in RED.
Correct. So our goal would be to try to retain as many of these patients here at Rutland Regional so that there would not be any travel or transfer costs associated with them.
But we haven't calculated this out, the direct cost that would be incurred by patients and families, I think. Have you? I haven't.
if they were to be transferred and they haven't been transferred today?
Well, so you have your 250 patients that are currently getting admitted. Of that, you're talking about a new 85 of those patients you think would likely be transferred. So there's 85 that would be transferred that have all these additional expenses in the future state that they don't have in the current state. And then you have all these other patients that then we have some sort of, I mean, you were talking about charges too, which is different than reimbursements because again, I'm interested in seeing it, but it looks like you have a really low collection rate on commercial compared to your charges. So charges are not really, charges are charges. It's really what's paid is what is the cost for the payers and patients and state and all that sort of thing. So anyways, I don't see it. So I do think there's this group of 85 potential people, families, kids that are going to be transferred that would incur a much likely, to me, it looks like they would incur a much higher expense of care.
So I think
Less
an
cost
important
for Rutland.
statistic.
Yeah.
So we haven't provided this statistic to you, but I think an important statistic is the percentage of our patients that come through the ED before admission and the percentage that are direct admitted. So I think that would be helpful in your deliberations.
All right, there was some questions about alternatives, and so I'm just going to throw out some questions on alternatives. One is, in this process, did you reach out to other hospitals that manage small inpatient pediatric units and what their sort of nursing or financial models are for these things, and to see if any of those would work for Rutland, and if so, which hospitals?
We did talk with hospitals that both do take pediatric patients, but also those who don't. And so we've, talked with some hospitals in the area. I specifically within the Porter, Saratoga, Glens Falls, to see how they manage their pediatric populations within their surgical volume, within their emergency department, and how they manage those patients from a adolescent standpoint on alternative inpatient units, as well as newborn care.
And what did you find out about how they manage this?
There was it was a pretty common response that that risk of not being competent because the volume, the need for inpatient pediatrics is so low that they felt that their staff were not able to maintain that competency, which is why they redirect that resources to their ED and PACU staff.
And Philip Lapp here, that's aligned with the shared vision that we've heard around these transformation conversations. In 2021, the Green Mountain Care Board talked about low volume programs having the potential to provide lower quality of care. There's been discussion from the Act 167 community engagement around the potential to discontinue low volume services or procedures because of concerns about the ability to maintain quality of care when your volumes are so low. So I think this is not a new concept.
Yeah, I think that the challenge that I think that portrayal of the discussion kind of slides by a little bit is, how do we in a rural state balance access to essential services that are needed in the communities with the reality that some of these services are fairly low volume, and we have very few options for admitting pediatrics in Vermont. So how do you balance the volume with the quality?
Well, this is Kelly Watson speaking. that's why we want to focus on the areas of our hospital where we currently have the highest volume of pediatric population, which is our ED. And, our goal is to try to retain as many pediatric patients within our community. That's why we estimated, 60 up to 80 patients may require transfer, not that they all necessarily would. Which does seem to be a common practice in some of the other hospitals that we spoke with.
And let me just, on the clarification of the hospitals, so were there hospitals that you spoke with that do continue to have inpatient pediatrics in this 31 to 15-year-old range, not the neonates, not the adolescents, but the middle of pediatrics there, that successfully do it, and that successfully do it, that are non-academic? Did you reach out? Were you able to connect with any of them?
I did not connect with anybody specifically, but I do believe that there are some non-academic facilities that do continue to provide care for pediatric patients in units that are blended. But I can't speak to their competencies or their volume. I did not speak directly with them.
Okay. All right. Thanks. I had a lot of questions, and there's a few to follow up on, but I really appreciate your candor on that. Thanks so much.
Thank you. Member Teachout?
Thank you. I want to start with a couple questions about how Medicaid is paying Rutland Regional for pediatric care, because that's the majority of the patients in your pediatric unit. So first, I want to know if Rutland is participating currently in the Medicaid Next Generation payment model, and if you will be participating in the new Medicaid Global Hospital Budget Model for 2026.
We do participate in the ACO for Medicaid, and we do have a letter of intent that we have signed with the AHS to explore the GPP. Our decision hasn't been made yet. That is due on December 12th.
Okay, thank you. Who was speaking?
That was Jen Bertrand, sorry.
Okay. So as part of that approach, and I think it's interesting in this case because the majority of the payments and the patients are Medicaid in this particular instance, Medicaid, at least up until now, has been paying you in advance, I believe, monthly for the care of their patients in your facility. There's a lot of theories about what this is supposed to do: increase flexibility, ability to meet the needs of the patients. What was the experience of Rutland in this case?
You're meaning our fixed payment under the ACO?
Yes.
Well, that's based on a trend rate from prior, so they would have taken trend rates into account to set that payment methodology, I guess, is perhaps what you might be asking about.
I guess so, and that means that if you eliminate these services, the trend will be readjusted downward?
That is part of the discussion with AHS in terms of their new GPP model. There are certain service lines when you submitted an LOI that you let them know could be under consideration for a certain threshold, depending on the size of the hospital, of what that adjustment may look like and how they set their GPP for the following year.
Okay. And do you think that the reason that a majority of the pediatric patients at Rutland are covered by Medicaid is because of state policy choices we've made?
I think that's a very hard question to answer. I mean, if you look at our demographics, and it is in line with our demographics, but we have expanded Medicaid in the state. I do worry about what that looks like in the future, what changes at the federal level and in the redeterminations and such.
Okay, thank you.
And that was Judy Fox.
Yeah. So just another question. How will you decide if a patient is going to be transferred to the University of Vermont Medical Center or Dartmouth or anywhere else?
That's Dr. Davis.
Yes, so those questions, first we generally will go to the patient and family if they have a relationship with one of the tertiary care hospitals already. Then that would be our first choice, capacity allowing. And then it depends on capacity, really. So oftentimes the patient might they may live north of Rutland and they may want to go to UVM, or they may have a pediatric endocrinologist at Dartmouth, or live in Bridgewater and they may want to go east. And so those decisions are really made based on first patient preference and second capacity allowing.
So is it not made based on the clinical specialties in the hospital, but where they're being transferred?
As far as pediatrics goes, they're very similar offerings in terms of pediatric subspecialty care. They both have PICUs, they both have pediatric endocrine, they both have PD pulmonary. So I wouldn't say that individual organization offerings are necessarily a priority in that case. Just thinking out loud, sometimes there's pediatric ophthalmology at one hospital and not another. And so you might call one organization and they say, we don't have PD optho on today, please call somewhere else. We call somewhere else and they have PD optho on. So something like that could happen, certainly.
Okay. And is there any, research or clinical information about what the intermediate step of being admitted to the Rutland Regional Medical Center ED and then transferred to another ED, what the outcomes are on quality versus just driving further on your own to a different facility? Because I'm not exactly sure how patients will respond once they know that this is no longer an option at Rutland.
I'm not sure what you mean by quality outcomes.
Yeah, I'm not sure I understand the question either. But I will. This is Kelly Watson. I will say that the need for the inpatient unit has continued to decrease. And we're seeing the vast majority of our patients stayed for fewer than 24 hours. So I would really encourage families to continue bringing their pediatric patients to Rutland Regional Medical Center because we are confident that we can care for them in our ED without having to transfer them.
Right.
And that inpatient status is only projected to decrease in need with more of that less than 24-hour observation need.
Right. And I'm just asking a question about whether a family who doesn't know anything about the specifics of what Rutland covers or does not chooses to bring their child directly to a different facility rather than go through your ED and get transferred. Are you worried about losing families bringing pediatric patients to your hospital as a result of this decision?
Well, I would hope that we don't lose those patients from coming here, and I hope that we can share with our community, and I know that we will, that this is still a place that you can bring your pediatric patient to receive really great care. I would hope that through communication and ongoing efforts to provide great care that that people won't want to take their care somewhere else.
Okay. I have another couple questions about access. One is that I know that hospitals further than 10 miles from the Vermont border, with the exception of Dartmouth, receive lower payments from Vermont Medicaid for the patients who go to those facilities. Also, if you're going to an out-of-state facility, and I believe that Dartmouth is also an exception along with a couple other facilities, it requires prior authorization from Medicaid. How will these sort of factors in coverage impact your ability to transfer pediatric patients?
So this is Judy Cox. I think it's important to note that we transfer pediatric patients routinely now. And We see this as not new activity, and certainly our emergency department teams know how to work with hospitals both within our state and in surrounding states. So I don't see this as a new issue that we have to counter. It's something that is very routine in our care today.
So aren't most of the patients that you're transferring now high acuity, and the ones that you will be transferring not the lowest acuity, but sort of this middle range? And isn't that a difference in making those transfers?
So Dr. Davis, I'll let you take that.
Is the question around the requirement for prior authorization?
The requirement for prior auth, right, is one concern. And the second is the lower payment rate to out-of-state facilities. Will that make it more difficult for you to transfer these not super high acuity patients?
I mean, I think that our patients are protected to some extent under EMTALA, which, accepting hospital with capacity cannot refuse a patient based on insurance status. So the hospitals that we would be transferring to are within the state or Dartmouth, or Albany if UVM and Dartmouth don't have capacity. But again, I think that if a patient is in the emergency department and requires a service that we're not able to provide, then EMTALA protects that patient. They can't be declined based on their insurance coverage. The hospitals have an obligation to, if they have capacity, to accept the patients without consideration of their insurance up front. If I'm understanding your question correctly, I hopefully I'm on track here.
Yeah, that's part of it. And then will the prior authorization process slow down the transfer?
So prior authorizations aren't required for this sort of admission. I've never had to get a prior authorization for an inpatient admission for a patient in the emergency department who requires admission.
Okay, from Vermont Medicaid.
Not for a medical patient.
Okay. I am a little bit worried about network adequacy for pediatric patients, especially in the southern half of the state, who will need to travel somewhere else for these services. And I think some of these factors impact their ability to access care in other places of the state. I did have another question about the emergency department at Rutland Regional. We've been hearing across the state for a number of years now that there's too many patients waiting in emergency departments. And this is a problem that's been cited by hospitals across the state. They're waiting there for a number of, system issues. How does shifting pediatric care from the inpatient unit to the ED impact this challenge for Rutland Regional, and then the other facilities that they'll have to go through the ED?
So our ED length of stay, our left without being seen rate, and our boarding times and throughput are all metrics that we watch very closely. We're very fortunate relative to hospitals nationwide in that we hardly ever are boarding patients in our emergency department. Our left without being seen rate is in line with national benchmarks, as are other throughput metrics. Again, we're talking about, realizing that every day is a little bit different. On average, we're talking about a handful of patients in the context of 100 patients that we might see in a day. So I do not anticipate this being having a huge impact overall on those quality metrics.
Yeah, and I'm sorry, this is Sheena Fisher. I'm the nursing director of the emergency department. here at Rutland Regional. So we track our census, and we have for 6 years, every 2 hours. We document that. What we have done is taken the anticipated increase in the pediatric volume and overlaid it with our average hourly census per day of the week, per month of the year. And we looked at that. We looked at our staffing model that correlates to the average number of patients we have per every 2 hours at our department. And we reallocated some staffing, and looking at the numbers, we can definitely sustain increased lengths of stay and this very small subset of patients, and safely staff for their care needs throughout their stay with us.
Okay, thank you. I did have, I think, 2 more questions that were just follow-up to Dr. Merman's. One was on the total cost of care analysis that you did, and I look forward to the clarification of how, the assumptions and the methodology that you did there. But just say we assume that the overall net savings it's $229,000 in savings to the entire healthcare system in the state of Vermont. That's what your total cost of care analysis is?
That's our analysis based on the low volume of inpatient stays that we do have for that particular unit. Yes, that's the calculation that we have.
Okay. And then my next question is on the 3.1 million in savings that you say Rutland Regional achieves through this system-wide efficiency redesign. And I believe that's the 3.1 is an annualized number that comes out of the 9 months that you calculated in a different place, which is maybe where some of the confusion was here. But it looks to me like you're still projecting losses. So you're saying that it's a savings to the hospital. This is a Rutland Regional specific savings, but it's just losing less money. Am I correct?
The service itself would be, well, it loses money now. So if that service is combined, then we would have less of a loss to the bottom line. That's correct.
Right. So currently you're losing about 4.6 million, right, in the current year. You project that with the redesigned model, you will lose 2.4 or 2.34 million on a 9-month basis. I don't know what and so the difference is a $3.1 million savings on an annualized basis.
The 2.3 million is the impact savings we would get when you take the current model that we have today. You remove the reduction of the FTEs that we talked about, because most of this is that savings in the salary line. And what you're left with is that impact. And that impact is that 2.3 million for the 9 months and then 3.1 million annualized. If we look at, go ahead.
What is the 3.1 million as a percent of Rutland's entire budget?
So our expense base is 350 million. Our roughly, I'm going off the top of my head, that's generally what about our expense base is. And then our operating margin, as you know, during our budget process, we are anticipating operating at a loss in 2026. But in prior years, our operating margin could vary anywhere from around 6 million to we've had losses in the past, but we anticipate in a good year at a 2.5% margin, we may be able to yield $9 million in operating from that, if that helps.
Yep, it does. Thank you. That's the rest of the questions that I had for now. I'll pass it on to whomever's next.
Thank you. We'll turn to Member Walsh.
Thank you. And thank you, Rutland, for being here this afternoon. And I know there's been a lot of questions already. I'll try to keep mine direct and concise. Your materials describe months of evaluation, yet many public comments from families, your staff, and community members say they felt left out. So I'm wondering if you would describe your strategy for engaging your board, your clinical staff, and the community as this decision was developed.
Sure. So I'll take that. This is Judy Fox. So we have engaged our board along the way. Our concern was one that we did not want to scare our workforce into thinking that there was going to be a change if in fact the results of our research led us to a different decision. And so we felt that to keep the integrity of the program prior to understanding what our final decision was. It was our goal to include and have those stakeholders after having made the decision to help us really create a care redesign that provides us, again, as much care here in our community and with highest quality and efficiency.
Thank you. That's helpful context. Even with the declining volume that you've outlined in your presentation and your responses to questions so far, the Act 68 asks us to consider whether reasonable alternatives could preserve necessary services. You mentioned several options, and in your submission you outlined 3, but it's still not clear to me whether you evaluated the possibility of maintaining something less than 5 beds, but more than 0. Could you
Yes.
walk us through how those middle ground options were assessed and why they weren't pursued?
Yes, certainly. And so Kelly Watson, our Chief Nursing Officer, can talk through that decision well.
Sure. So I think when we look at our average daily census, the majority of the year, it's less than 1. So really, we're already operating with less than 5 beds being occupied already. And it's already, we're seeing times when we can't even staff that. And that volume is projected to decrease. So if we're already half the year with an ADC of less than 1, and the projection is that it's going to continue to go down, there really wouldn't be any change in that respect.
I see. Thank you. You described, well, I'm sorry. There's been discussion about the declining volume and quality. The relationship between volume and quality in pediatrics shows a very strong relationship for highly complex surgical care. But it's a much weaker relationship and it's inconsistent when it comes to common pediatric medical admissions. So did you review that evidence when evaluating any middle ground options, or was it solely the number of declining admissions that drove your decision?
Philip Lapp here. I think that it's very difficult for us to measure internal quality metrics when we've got such small numbers and it's such a small N. I think the general theme is that when we are caring for so few patients a year, it's hard to attract and retain and develop and maintain competency for the nursing staff when there's so many beds, so many days when there just aren't children in those beds. I think that's kind of the. Go ahead.
Yeah, no, I understand. It's there was a lot of discussion in your submission and early in the presentation about the concern about declining quality. But my question was to try to highlight that that's really a very small, specific part of pediatrics. That the research is much less consistent on the type of admissions we've been talking about. So the lower volume is not necessarily associated with lower quality for these types of admissions.
So we have had we had a former contract labor staff share that they were unable to provide care for one of our pediatric patients for something like starting an IV. And they relied on our ED pediatric nurses to come up to be able to establish that IV to administer the medication that the pediatric patient needed. You know, that's an example of how, you know, with fewer and fewer inpatient needs, keeping up that clinical competency is at risk. Whereas in our emergency department, when they're seeing, you know, close to 4,000 patients a year versus 237, the routine practice of those clinical skills are there.
Thank you for that example. That makes sense. I appreciate the clarity. You've described the emergency department rooms and redesigning to make some of those more private or child-proofing them. But I haven't heard you describe any discussion of alternative models like pediatric observation units or step-down models or swing beds. Those are common in other rural settings, and I'm wondering if you evaluated those, and if so, why you decided not to pursue them. Is it purely just a numbers issue, the way that it's sounding in your most recent answers?
So I think this is Judy Fox. So it comes down to numbers, right? There have been multiple times where we've had to, as we've said, close the unit to inpatient admissions. Whether you have 5 beds or 2 beds, the fact of the matter is if you don't have patients in those beds, and for Rutland Regional Medical Center, almost 50% of the days in a year, we have no inpatient patients. It becomes very hard to staff a unit with individuals who have a passion to take care of patients. And that is what we're finding. One could say we have a 2-bed unit now for the most part, if you look at utilization.
And hi, this is Kelly Watson. I'll just tack on to that. Thank you, Judy. I think too, when we look at the capacity in our ED and we look at bed availability in the ED now, we're confident that we're able to accommodate those patients that may remain in the ED. And so at this point, we have that capacity. That's not to say that we're not working with that multidisciplinary committee that Dr. Phil Lapp and I are co-facilitating to look at other options within the ED, you know, it's down in the future, what that might look like. But at this point in time, we have the ability to care for those patients in our ED now, and we have the ability to continue providing that care safely.
Thank you. That's helpful. A couple questions about financial assumptions and Medicaid reimbursement, like some of my other colleagues, but just slightly different. But what I'm sensing from this conversation is that even if you were able to secure greater reimbursement from Medicaid, for example, the volumes are so low that your findings so far suggest that that would not be sufficient. Is my sense of this conversation correct about that?
Yes, you are correct.
Okay.
The cost would still exceed that reimbursement rate.
I understand. There's been a discussion about transfers, and did your analysis include the financial impact of those transfers on families and members of your community? I'm asking this because Act 68 asks us to assess not only access, but affordability. And it's not clear to me that this would make anything more affordable for the members of your community. Can you help me understand if you considered that and how you weighed that.
We did consider it because we felt that most of those patients we could retain here in our ED, and therefore we are already transferring patients today. There is that subset that we already have, and there could be, you know, a smaller percentage of maybe some of those patients that we could not care for in our ED today. But that thought process did go into this, where we felt that we would be able to maintain a good portion of those patients because of the acuity level here at our RMC.
Okay. Thank you. And one final question. I think I know where it's going, but I still want to ask it, have it with the record. Your submission cites the Oliver Wyman report from 2024. That report has informed our discussions and it's set some directionality, but it hasn't been developed. It hasn't been adapted as a statewide plan. And Act 68 anticipates more coordinated planning for future service changes. So in the absence of a framework right now, what criteria did you use to assess, or how did you arrive at, how did you conclude that this was the right moment to make this change, given that we do not yet have a statewide plan?
Yes, so this is Judy Fox. Again, I wanted to just take us back to, we use this 5-step framework to really help inform our decisions. And I want to also kind of reiterate that we're really leading with our concerns for low volume and ability to staff the unit, and because we have seen where the unit has denied admissions, or there was a weekend we were shut down altogether. Whether this is approved or not, I just want to be very clear that we have to have a response to staffing in our unit because we are seeing times when we just don't have the ability to accept patients. And so that is why we think this is so urgent.
Thank you. I appreciate the clarity of that response. And those are all the questions I have. Back to you, Chair Foster.
Thank you very much. Member Holmes?
Yeah, thank you so much. And actually, a lot of my questions have been asked and answered, which is helpful, but I do still have a few more. And I'm wondering actually if you could pull up the slide which has the pediatric inpatient decline, the 48% decline, 2003 to 2025. Is it possible for somebody to pull that up? Isn't the presentation? Thank you. Sure.
Slide 14 also.
Perfect. For some reason, I have a big black mark down the middle of that, but actually it's kind of a helpful black mark, as it turns out. I don't know if it's on other people's screens as well. But I want to, before I talk about this chart, I just want to say in the submission, it says the key financial assumption is the continued pediatric inpatient decline of 48% since 2003. So the continued decline of 48%. And I guess when I look at that chart, and if I were to move that black bar over, if I were to look at that, I would say from the last 10 years, if we look at 2014 to 2025, it looks to me like there's been pretty constant, or frankly, a slight uptick in volume 2024, 2022, 2023, 2024. If you kind of focused your eyes between 2014 and 2025, you'd be hard pressed to say this is an era of decline in inpatient volume. And I would say, frankly, it looks like, the last 3 or 4 years have been among the highest, but for 2019. So I just want to question, a lot of the conversation has been around continued decline. And I want to say, I'm not seeing that here when I look at this graph.
So
If you look at the last decade, or in the last, 3 or 4 years relative to the last decade.
So this is Judy Fox again. I think we have to get this slide in coordination with the two other slides where we looked at the average daily census, which is the slide following this. So with, maybe it's a slide before, sorry. So as we look at those slides, as we look at that average daily census, what we're seeing is that for the most part, we are looking at a census that has well below a patient a day for many of the months. There we go. Whoops.
No, I understand that, but I guess this is about, an average daily census for 2025. And I recognize that there are many days where you don't have a patient in there, but I do want to point out just that if you look back over the last 10 years, seemingly this has been somewhat of the norm. I mean, we don't have the average daily census for the last 10 years. And so maybe it would be helpful to understand how that average daily census has changed in terms of, this distribution that you're showing right now. But if you look at that trend line, it's helpful, of course, to go back to 2003. But if you went back to 2014, it's a different story from that graph.
So there's a piece of it, actual volume today with very low average daily census, which if we could go to the next slide, please. There we go. You can see how challenging it is to keep a unit open when your average daily census is well below 1 each day. You compare that with SG2 and where they're looking at trends, and I get that this is a national trend. But looking at the types of patients that we treat with these trend rates, it is looking as if we are going to continue to see a declining need, if you will, for inpatient services, and this is really a result of advancements in our vaccinations and the ability for our pediatricians to care for patients in their facility as well as home health, quite frankly. So really looking at all of those different care design patterns as well. And then, to bring costs into this, I guess what I would say is when we had the ability to suffer losses with low volumes, when we had operating margins, it was easier to carry those costs. It's becoming increasingly more difficult to carry costs for low volume units, and as is kind of demonstrated in this year's budget, where we actually submitted a budget with a $5 million loss. So we just don't have the bottom line and margin to subsidize some of these services.
Yeah, I can add. Oh, sorry.
Well, no, that's okay. I mean, we don't have a lot of time, so I hear what you're saying. And I guess I want to say is it's hard for me as I'm listening in this hearing to know whether it's a supply problem or a demand problem, in the sense that I think I've heard a few times that sometimes you can't admit kids because of staffing, which also tells me, does this data, is this an underestimate of your demand? In the sense that there have been times, I suppose, when you've had to perhaps, it sounds like, transfer patients because you didn't have staffing to be able to admit them to your own unit. So it's hard to figure out, is this a demand problem? Is this a supply problem? Is it, a reimbursement problem? Is it a quality problem? There's a lot of information that you've shared with us today and in the submission. Let me ask you a different question around the quality issue, because you started the presentation as this is a quality issue. And so when I look at that trend line, and if you can go back to the other one, which is the average daily, the inpatient, not the average daily census one, the trend from 2023. When I look at that graph, if we get to it, I guess what I would say is this is a decision that's coming now, but we've had relatively constant, volume in that unit for a few years, slight uptick, as I might say. And you gave an anecdote about one nurse who had a hard time starting an IV, but I'm wondering, have you seen measurable, quantifiable declines in clinical quality that you would be willing to share with us that support that this is a quality issue?
So, hi, this is Kelly Watson. So just to go back, I think to your prior thing really quick about transferring patients because we couldn't admit. I just want to clarify that those patients were cared for in our ED. So to my knowledge, not transferred because of admission. Okay. But I also want to point out kind of two things here. The fact that the majority of the patients that do end up being cared for on the pediatric in those pediatric beds stay for less than 24 hours. And 92% of those patients fell in that very low to low acuity. So, you could say that the average daily census may actually be higher than it needed to be if those patients had perhaps been cared for in the ED versus going to the unit for less than 24 hours. So I just wanted to point that out there. And I also want to state that I do believe that our current staff provide excellent care. This is not a reflection of any poor care that our team is delivering. We're very proud of our staff, both nursing and support staff. But with this decrease in volume and the projection that it's only going to decrease, we are at risk for not honing in on those clinical competencies. And we are in situations where we periodically have to, say, if you have an admission, we're going to redirect you to the ED because we don't always have staff available. Staffing a very low volume unit is very challenging.
Okay.
And I think the only other example is, it can take upwards of 6 months or longer to orient somebody new to the department because there's so few opportunities to care for pediatric patients that it takes longer to try to orient.
Yeah, and I guess let me ask this question because you mentioned, I've heard it a couple of times, that the ED has sufficient volumes to be able to maintain the quality and the competency. So having peds patients cared for in the ED would allow that maintenance of quality. But my question to you would be, why not, instead of moving peds patients down to the ED, which I've been in a number of EDs, they can be scary, they can be loud, they can be not particularly friendly to children, I would imagine, because they're not particularly friendly to me when I've been in there in the sense of the environment and sometimes what you're hearing and seeing and experiencing. I guess my question to you is, why not rotate your staff through the ED at times so they have exposure to the higher volumes, they have opportunities to maintain their skills and keep the peds patients up in a safer, quieter environment?
Hi, this is Sheena Fisher, Nursing Director of the Emergency Department. Good question. So our emergency department nurses are skilled to speak or to treat very sick patients that come in with sepsis, with trauma, with acute needs. Our inpatient pediatric nurses do not have that skill set. That is not where they are able to operate. The other part to working in the emergency department is, yes, we see about 3,500 medical pediatric patients per year. We need to have those patients be cared for with the people that have the higher acuity skill set. We also have the, with our nursing staff and our nursing union, we are not able to mandate staff go between an inpatient unit and a pediatric unit, or in our emergency department. So during these times where we've had an average daily census of 0, the staff and the nurses on our women and children's unit have had the opportunity to come down and have elected not to. But again, because of our union, we are not able to mandate staff float between units. So good question. I hope that provides a little clarity.
Okay. Let me just quick to a couple of other questions that I have. In the submission, you stated that 90% of inpatient peds admissions come from Rutland. And I'm also wondering, as an alternative approach to increasing volumes, improving financial viability, potentially quality, did you explore at any time expanding your pediatric service and including patients in neighboring counties? Specifically, did you reach out to pediatricians and hospitals in neighboring counties to see if they might redirect referrals to Rutland rather than, say, Dartmouth or Albany or elsewhere? Did you explore that at all?
We did not explore that, as we see kind of our neighboring hospitals. The UVM Health Network is kind of focused Northway. We do have the Bennington area that is caring for their own children. So it's a very small subset of hospitals.
Okay. This was asked slightly, but I'm going to ask it just more directly. I think during the last 6 or 8 months or 5 months when you were undergoing this planning process, did you at any point specifically reach out to DVHA AHS to request an increase in inpatient reimbursements for the PEDS unit or the WACU generally?
No, we did not. It's been our customary experience that we don't receive increased rates, so we did not reach out to them.
But you were at this time working on care transformation in a regional planning effort and thinking directly through with AHS care transformation and where services might be and the financial viability of certain service lines, presumably in those conversations. So I'm curious as to why this didn't come up in those conversations to maintain a necessary service in a community that was, highlighted in your community health needs assessment as, youth are a vulnerable and vital population, and access to specialty care was really critically important to your community.
Yes, so with all of the focus on rates in our state, that felt like it was kind of counterproductive, to be honest. And again, I also want to say that this was really a focus on how we can staff a unit and not necessarily led with reimbursement.
I guess I'm trying to understand, is this about staffing a unit? Is it about quality? Is it about the financials? And I understand it can be all related, but I'm trying to understand this. So because there may be different solutions depending upon what the root of the problem is. Let me switch gears a bit to, I guess I'm just going to ask for a little bit of clarity, like my colleagues before me. The financial tables and the estimates of the annualized savings of $3 million and where that's coming from. I just want to reiterate, it was not clear from the submission how those numbers were calculated based on what, reductions in the 8.5 RNs, the 4.2 LNAs, and all traveler FTEs. It seemed like it was across all 3 units, not just the PEDS unit. It was also unclear if you can clarify if you're hoping that the 13 non-contract labor move to another position within the organization, how that affects the $3 million in savings. Is the $3 million in savings just the delta between having somebody in a permanent position versus having that person have been a prior been a contract position. It's not clear how those calculations were made. If you can clarify now, or that would be helpful.
So let me clarify, because it's probably counterintuitive, because we're using net revenue for the pediatric experience and we're using expenses for a combined labor, what we call an LDRP model. That LDRP model has been something that we've been working toward for a couple of years now, to where we would be consolidating the units regardless. The pediatric revenue, when we redesign this service, would be going away. When you combine all that staffing so that we could maintain the quality and the competencies, and you combine all of those of this LGRP model, that's where we go from the 27 FTEs to the 14 FTEs, and where there's that savings. Hopefully that helps clarify, because I think that might be the piece that I didn't express earlier that might have helped in this, is that we are looking at the expenses from the combined and consolidated units, because that is also changing in this equation. And Kelly, I don't know if you want to add to that.
Correct. Hi, this is Kelly Watson. I can add to that as well. So currently the labor and delivery department is physically located in a different area than the women's and children's unit, which houses those pediatric beds. So we're staffing two physically separate physical spaces with largely, no pediatric